Good afternoon, everyone. Thank you so much for joining us for the Jamaica Midlife Health Society's first webinar of 2024. Thank you so much for joining us. The topics today that will be discussed are centered around the theme of foot care, keep walking at midlife and beyond. I'm Samuel from Oldgate Solutions, and it's an honor to be a partner on this webinar with the Jamaica Midlife Health Society, and I just want to thank them right away. So, quick answers to the questions before they come in the chat. Yes, there is a pre-test. Yes, there is a post-test. Yes, I will share both of those in the chat, especially the pre-test, which I will share now. And yes, there are 3 CMEs which you will have to pay for if you are a physician, nurse, or medical practitioner. This is not accredited by the Pharmaceutical Society of Jamaica, so it's not for pharmacists. Other than that, we thank you for joining, and I now hand over to our moderator for the session, which I believe is Dr. Lisa Kervin-Dawes. Dr. Kervin-Dawes, over to you.
Thank you, Sam. Thanks for actually letting us in, and welcome to everybody. Welcome to friends, old friends, new friends, and soon to be friends, and to all our colleagues. It's the Jamaica Midlife Health Society's seminar on foot care, keep walking at midlife and beyond. I just want to welcome all our sponsors and everyone, because the major welcome will be by our president, Dr. William Brown. So to keep time going and not take away from anyone, I am going to hand over to Miss Cooper Denuse.
Yes, thank you, Dr. Lisa. In preparing to do this session, which is really the prayer, I thought I would go into the Bible and search out the 2 words, foot and feet. And in the King James Version, foot appears 91 times. And Psalms 94:18 says, when I said, my foot slippeth, thy mercy, O Lord, help me up. And for feet, the word feet appears 239 times in the King James Version. And I like this text as well. Psalms 119:105. Thy word is a lamp unto my feet and a light unto my path. So as we listen this afternoon to foot care, keep walking at midlife and beyond, let us keep these texts in mind and let us take some notes and enjoy the session. Let us pray. Father in heaven, thank you so much for this opportunity you've given us to meet as a JMHS team and to be able to put on and have this seminar, this webinar on foot care. Dear Lord, many times we tend to not care for our feet, but we now know we need to care for it. And we thank you so much for this topic. Be with everyone who is here. May we learn something, and not only learn it and keep it to ourselves, but share it with others so that others can learn more about their foot care and their health as they go through midlife and beyond. For Christ's sake, amen.
Amen.
Dr. Brown, do you want to take over?
Yes, thank you very much, Lisa, one of our 3 moderators. Thank you for being on time. Good afternoon, everyone. Before I bring the greetings, I just want to let you know that JMHS, which is Jamaica Midlife Health Society, is an approved charitable 20-year-old non-profit NGO organization which operates under the auspices of the Medical Association of Jamaica. Our mission is to educate persons on health-related problems associated with midlife and beyond. And I think those who are approaching midlife too. Prevention is better than cure. So JMH is an approvable charitable organization, as I said. And since COVID, but before COVID, we used to meet face-to-face. And now we're looking at webinar meetings. And in the near future, we're going to look at the hybrid format where we have both face-to-face and online meetings, which continue to be very successful with a mixed audience of medical and non-medical attendees. Our paid executive secretary assists in communication across the various media platforms, resulting in our growing numbers and participation and interest. Last year, we looked at prostate and cardiovascular diseases at the midlife and beyond, and we tackled erectile dysfunction expanding treatment options, preventing cardiovascular disease at midlife and beyond. And then we looked at mental health inventory at midlife and beyond. And we had a question, has COVID-19 affected mental health issues at midlife and beyond? That is preventing and managing mental health issues post-COVID-19 at the midlife and beyond. And our final one last year was entitled The Impact of Menopause and Andropause on My Skin, My Vision, and My Oral Health. So we looked at understanding hair and skin changes at midlife and beyond, maintaining our best oral health, and preventing and managing our deteriorating vision at midlife and beyond. This year, we're presenting topics on foot care, which is for today. In June, we'll be looking at preventing mental health challenges in midlife, early risk factors identification. And finally, in October, we'll look at healthier lifestyles at midlife and beyond. Quality of life matters. So why is foot care important to seniors? That means being as mobile as possible. That's why we say keep on walking. And our feet are the first thing that hits the ground, keep us balanced and help propel us throughout the day. This makes foot care crucial to overall foot health for seniors. And as we age, the body goes through many, many changes, and the feet are no exception. So in fact, 1 in 4 older adults experience foot pain, as we see in our practices on a daily basis. What is foot self-care? Well, we shall explore that today. We shall look at the challenges in foot self-care for the elderly. We shall look at how aging affects our feet and ankles. So we take this opportunity to invite the participation of more medical doctors and nurses, the support of the MAJ and its affiliates, and the ongoing collaboration with other stakeholders so we can fulfill our mandate of educating persons on health-related problems associated with the midlife and beyond. So on behalf of the executive and members of the JMHS, I warmly welcome our patron, Mrs. Marigold Harding. I also welcome Professor Sir George Allain, who was former Chancellor of UWI, who would be doing this meeting, opening this meeting, our 4 presenters, our numerous sponsors, our members, attendees, visitors, and well-wishers to the first of our series of webinar presentations for 2024. We hope you would find it a worthwhile time as you learn more about healthy lifestyles. So you can join us for the next set of webinar presentation later this year. Welcome to everyone and welcome. Thank you.
Well, I just go ahead. It's my pleasure and my honor to introduce to you all Professor Sir George Allain, a Bayesian by birth, but a pan-Caribbean gentleman who has served as Professor of Medicine at the University of the West Indies and as the Chancellor of UWI. He's served as a director of PAHO, and he's worked with the WHO and United Nations on behalf of the Caribbean. Today, Prof. Allain is with us to give support to the healthy midlife movement as we continue to promote optimal health, wealth, and happiness as we age. Professor Sir George Allain, welcome, sir.
Thank you very much. Can you hear me okay?
Yes.
Thank you very much indeed.
Yes.
And you're my friend for life. I had asked if you made the introduction less than 1 minute. You made it 59 seconds, so you're my friend for life. I'd like to thank the Society for asking me to address you. You've done me a favor because over the years, I have not thought as much about midlife health as I've thought about other dimensions of health. And I'm embarrassed to find that you're 20 years old, and this is the first of your webinars I am attending. I also like the allusion in the prayer to the biblical reference to the feet, not only in the Bible, but throughout literature and throughout aphorisms of various cultures, you will find feet mentioned very regularly. We know the expression, so-and-so has his or her feet on the ground. The importance of feet as being the balance. We think of the head as being the guiding aspect. In colloquial terms, we think of the head as guiding, but the feet is really what keeps us moving, what keeps us balanced, and what keeps us close to Mother Earth. When one talks about midlife, there's usually talk of the midlife crisis, the transition of identity and self-confidence. So it's good to hear midlife thought about in more positive terms, as your association has done. And as was mentioned by the previous speaker, you have the advantage of looking back on the days of youth, and you have the advantage of looking forward and thinking of yourself as a pivot between these two ages. You've lost some of the risk-taking of youth. You are now more balanced, both psychologically and professionally, and looking towards old age and what you can do to ensure that your old age is healthy and productive. I'll come back to that in a minute. Obviously, I won't go into the aspects of foot care. You have podiatrists among you, and that is the bailiwick of the podiatrist, who will speak of you of healthy skin, healthy nails, proper footwear, etc., etc., etc. I'm not going to go into that. What I'm going to do is to try to invite you to see the foot problems in a wider context, to see how your society that is interested in health has a wider remit, and not only the remit of these years of 45 to 6 or 40 to 65. I'm going to invite you to look on the foot problems as being a surrogate for what is an impending pandemic in the world, the pandemic of the non-communicable diseases. And I was pleased to hear that in the previous webinar, you dealt with the problem of cardiovascular disease. When we speak of the non-communicable diseases, we all will include mental health among them. We speak of cardiovascular disease, diabetes, respiratory diseases, and cancer. And there is no doubt that in Jamaica and in the Caribbean as a whole, we are seeing a tremendous increase in these diseases. And what I'm inviting you to do is to lend your voices as a group into what may be done, both at the public level and the private level, to stem what I've often referred to as a tsunami of the non-communicable diseases. It is said that if you look at the big existential threats to human life here on Earth, one is a pandemic, another pandemic will certainly come. There is climate change, and the non-communicable diseases as being the great threats, the existential threats to human life on Earth as we know it. Because with the increasing age and changes in lifestyle, these diseases are becoming even more common. When we think of these diseases in relationship to foot care, our mind automatically turns to diabetes. And I'm sure in your group, you have thought of diabetes. I'm sure that someone like Professor Rainford Wilkes, who is an expert in this area, has spoken to you about the prevalence of diabetes in Jamaica, that 13.7% of adults have diabetes. And what is impressive, that 1 in 8 people who have diabetes will have some problem with their feet. 1 in 8 will have one or other problem with their feet, which will impair their mobility in one form or another. So again, I'm inviting your group to raise your voices and to be advocates for the prevention and control of these non-communicable diseases. And to do that, obviously, we need to know their risk factors. And the common risk factors, I'm sure that someone has spoken to you about this, are tobacco, alcohol, inappropriate diet, and insufficient physical exercise. And obviously, in your group and relationship to what is happening with today's seminar, insufficient exercise has to be something you consider very carefully. Walking. I advocate for us, walking is a simple form of incorporating your exercise. And when people tell me, oh, I can't find the time to walk, I can't find the space to walk, I always say that's nonsense. That's an excuse. And especially in Jamaica, in spite of what some of my colleagues will talk about, the environment and the dangers of the environment, I would challenge anyone in Jamaica not to be able to find time and space to walk for 30 minutes a day. I would challenge you. I can have the excuse that when it is 30 degrees or 25 degrees here in Washington, I can say it is too cold to walk, but you cannot say that. No one can say in Jamaica that it's too cold to walk or you don't have the space to walk. So as a form of exercise, I am saying to you that walking is absolutely essential. And I think every one of you should be committing to walking as a form of exercise, as a means of controlling one of the risk factors for the non-communicable diseases. And I'm going to suggest walking not only for the exercise, but for the pleasure it gives. The idea to be able to walk along or walk with your some colleague, observe the environment and meditate on the environment. It is a pleasure which you can enjoy without having to necessarily depend on others or to depend on an apparatus. You don't have to go into a gym to have the exercise necessary to prevent the non-communicable diseases. Walking is adequate, perfectly adequate. And when we combine that with the moderation in intake, which I'm sure your group advocates, I think you have a perfect recipe. I've left out tobacco. Tobacco is one of the most noxious agents known to man. And I'm sure your group has thought about tobacco. And when I speak to groups about tobacco, the automatic question is that what about relationship tobacco and lung cancer and lung diseases? True, very true. But tobacco has an important impact on the vascular system. And the vascular insufficiency, which is a precursor to many of the foot problems, tobacco is a notable stimulator of the vascular insufficiency that is a precursor to foot problems. Obesity, the heavier you are, the more difficult it is to get out of bed and go walking. I hear that over and over again. So you control your obesity, your increased weight, to facilitate your walking, which in a sense, which also facilitates your predisposition to avoid your avoidance of the chronic non-communicable diseases. I'm emphasizing this point of yes, I have a minute and a half left. I emphasize this point of the midlife and having at this juncture being able to look back and able to look forward. I'm involved in a project with some colleagues from the World Bank, which speaks about healthy longevity, non-communicable diseases, and human capital. And the idea being, if you control human diseases, you facilitate the possibility of living longer, and you improve your human capital. Your human capital is the most important ingredient in a nation's wealth. And by avoiding NCDs at the population basis, you improve the capacity of your citizens to be wealthy. One of the things I neglected to mention when I spoke of physical exercise and walking, I give a lot of credit to the Minister of Health of Jamaica, Tufton, for advocating the Jamaica moves, trying to get Jamaica to adopt the slogan Jamaica moves, and not adopt it only as a slogan, but to practice Jamaica moves, looking for opportunities in which Jamaica can move. And the last point I'd make is this: at the at the middle point of your life, you are in a good position to think about what I describe as the rectangularization of life. Life being lived as a rectangle and not as a triangle. Life being lived like this, so you go up and you go right along, and you have disability in as short a period as possible at the end of life. And all of us, all of you at the midpoint of life should be thinking, what do I do? Or what should I have done and what should I do to ensure what I describe as this rectangularization of life, to live my life as almost as a rectangle and not as a triangle, to live my life not with a period of steady decline over the years, but of good health for a long period of time, then a very short period of time at the end in which we are afflicted, in which we encounter many diseases and problems that are inevitable. So one should think of this midlife as being the pivotal point of guaranteeing this healthy longevity, and a pivotal point also for another reason, that you've had the experience of youth, and you should be able to advocate more aggressively for adoption of these habits that you will discuss in terms of foot care throughout the life course, not only when you are at the midlife, but throughout the life course. So you are an ideal position to advocate for foot care and foot care as a surrogate for prevention of non-communicable diseases, and something to be thought of throughout the life course, at the beginning and the midpoint and towards the end. And you can advocate for prevention and control of these diseases as one of the things for which you will advocate. I believe with a passion that it is the voices of citizens and the voices of citizens groups that will make a difference in having government implement the policies necessary for the prevention and control of these diseases, which I think are critical for our nation's development. I look forward to the rest of the seminar, and I want you to remember just one thing from what I've said, is at this point, please be conscious of this rectangularization of life, living life well into the older years, and then having the period of disability as short as possible. And your emphasis on foot care as a surrogate for the disorders that might impede your enjoying this rectangular shaped life. I think this is a major undertaking, and I congratulate you on it, and I wish you well for the rest of this rest of the seminar. Thank you.
Dr. Lisa?
Hi, I think it's supposedly time for, it says, the overview of JMHS, the video presentation.
Okay, everyone, thank you so much.
My apologies.
We thank you for the presentation so far. And now for the overview of the JMHS. Thank you so much. So that is, of course, the overview of this wonderful organization, the Jamaica Midlife Health Society. At this moment, and has been happening before, we have up the pre-test. Please continue to do so for all the medical professionals who will be seeking CMEs from this webinar. But now we move on to our sponsors highlight, which will first have MSN Pharma, followed by Indus Life Sciences. And for MSN Pharma, we hand over to Damien and Sushen. So over to you guys.
Thank you.
So while Sushen brings up her presentation, remember everybody, pre-test is currently up. At the end, we'll have a post-test as well. And now Sushen is full screen, almost,
Yes.
nearly, almost.
Yes. All right. Good afternoon, everyone.
Afternoon.
Good afternoon.
Thank you for having us. MSN is really happy for being a part of this seminar. This is just a quick reminder of one of our key products at MSN. So today I'd like to talk to you a little bit about LD Nail, which is MSN's rosuvastatin. It is approved in 73 countries worldwide, and over 5 million patients are currently being treated. So as we know, rosuvastatin is a member of the drug class of statins. It is used in combination with exercise, diet, and weight loss to treat high cholesterol and other related conditions. Rosuvastatin have a high efficacy. It's a potent HMG coenzyme A inhibitor, and it lowers LDL, and it also, a key feature, increases HDL compared to other statins. It has anti-inflammatory properties, and it has a good safety profile in the fact that it is very selective to the target organ, which is the liver, and it has minimal potential of drug-to-drug interaction.
I
It
hate
is
to
used.
interrupt you, Sue. What we're seeing is not the changing of your presentation. We're just seeing your home screen with the rosuvastatin. Let me stop that here.
Okay.
Share once more for me. You might have two PowerPoints up. You'll see one that's where you are now and one that's still on the, just share the one that's where you are now, on the slide that you are now.
Let me maybe close the one that's open.
Sure. And then we just go
Yes.
again. No problem at all. I want to thank MSN Indus, all of our sponsors who have made this possible. I don't want to jump the gun with the vote of thanks, but definitely give a thank you and a shout out to all the sponsors. It takes cash to care, and today we're caring for the foot of everyone. Ready again, Sue?
No, I think I'm having a complication now with finding the slide.
All right, no problem. Let me bring it up on my end real quick.
Thank you.
While we're here, I believe I have a copy of it.
Yes.
I hope so. Here we go. All right, let me open it real quick and share. And you just let me know when to move to the next screen, and I will do that happily, okay?
Okay.
All right, so let me share screen now. That's it?
Yes.
All right.
I think we were next.
You can continue from here. Approve.
Okay.
Okay, go ahead.
Right. So as I was saying, the rosuvastatin with MSN is a member of the drug class of statins. So it's used in combination with exercise, diet, and weight loss to treat high cholesterol and other related conditions to prevent cardiovascular disease. So some key features of rosuvastatin is that it has a high efficacy as a start dose. It's a potent HMG CoA inhibitor. It lowers LDL, lowers VLDLs, and a key feature of the rosuvastatin is that it also increases HDL, and it has anti-inflammatory properties. It has a good safety profile in the fact that it is highly selective to the target organ, which we know is the liver, and it has minimal drug-to-drug interaction. It is used worldwide, and it is cost-effective in the sense that the LD nail is fully covered by NHF. Indications for the rosuvastatin is indicated in hyperlipidemia and mixed hyperdyslipidemia. Other cases it can be indicated for is risk reduction of MI and stroke. So the dosage we currently have now at MSN, we have the 5 milligrams, we have the 10, 20, and also the 40 milligrams available. So again, when it comes on to the safety profile, we know that it is hydrophilic, it is very selective to the liver, and it has limited drug-to-drug interaction. All right, so some take-home points is that it offers comprehensive lipid management. It is the best in the class of HDLC and LDLC when it comes on to decreasing those. And it is effective in reducing cardiovascular events up to almost 28%, and the withdrawal when compared to other rosuvastatin is less than 2.9% with other statins. 4 out of 5 patients showed coronary plaque regression in patients with established CHD, and nearly 500,000 patients in real life have shown rosuvastatin being superior in cardiovascular risk reduction. So I just draw your attention to this quick study. As you can see here, we have a comparison between a few statins, which is the LD nail compared to atorvastatin, simvastatin, and pravastatin. As you can see here, the required dose of the rosuvastatin or LD nail is only 10 milligrams to achieve 45 to 50% reduction in the LDLs, while atorvastatin requires over 20 milligrams and simvastatin requires over 40 milligrams to achieve 40 to 50% reduction. And pravastatin, even at the max dose, haven't been able to achieve this. Another study to the right compares the timeline that is required for these reduction goals, the LDL reduction. As you can see, the LD nail takes within 6 weeks to start working, while as you can see, it takes about up to 24 weeks for the other statins to be effective. All right, so MSN has the patent when it comes on to the rosuvastatin. So we're 100% bioequivalent to the brand. That's it for LD nail. If you have any patients presenting with hyperdyslipidemia, I ask that you remember our LD nail. Thank you.
Thank you so much. Great presentation. I believe
You're
the
welcome.
next presentation is from Indus, and Indus has supplied us with a video, so we'll just go right into that now.
Welcome to the world of Indus, and we are happy to join hands with you to serve the humanity across the globe through innovative healthcare brands. In just 16 years, Indus has grown from 1 to 120 products in 12 therapy areas. Today, Indus has spread its wings globally and is now present in 30 countries with 150 professionals spread across geographies like Asia, Southeast Asia, Africa, Europe, Caribbean, and South America. Excellence is not an act, but a habit at Indus. Our world-class products, affordable pricing, excellent supply chain, strong field force, and good business practices have accredited Indus with many excellence awards like Federation of Indian Export Organizations Export Excellence Award, Farm Excel Award, Brand of the Year Award in Ghana and State Bank of India Financial Discipline Award. What's more, now Indus brings you a 5-minute miracle. In today's fast and modern lifestyle, the incidence of heartburn due to acid reflux and GERD is alarming due to stress and busy schedules, overeating, eating irregularly or too quickly, eating just before bedtime, fatty, spicy and fried junk foods, caffeinated drinks, carbonated soft drinks, acidic juices and alcohol, and smoking. As published in many international journals, hyperacidity, acid reflux and GERD lead to heartburn. In hyperacidity, the excess acid from the stomach can move upward into the esophagus, known as acid reflux. As the lower esophageal sphincter, which joins the esophagus and stomach, becomes weak. Since the esophagus is not well protected like the stomach, the acid can irritate the lining and cause inflammation in the esophagus. This causes painful symptoms that can last for a few minutes to hours and can occur more frequently within a week. This chronic form of acid reflux is known as GERD, that is, gastroesophageal reflux disease. The major symptoms of heartburn due to acid reflux and GERD are a burning feeling in the chest, epigastric pain, a bitter or sour taste in the mouth, nausea after eating, regurgitation, frequent burping, flatulence and gas, stomach discomfort, difficulty in swallowing, sore throat and dry cough. The question now is, do regular antacids help? In hyperacidity and GERD, regular antacids can only neutralize the acids, leaving acid reflux unattended. To treat hyperacidity, acid reflux and GERD, Indus Life Sciences comes with a unique third-generation antacid named NewGel, which controls acidity, prevents reflux. NewGel offers balanced combination of alginic acid, magnesium hydroxide, dried aluminum hydroxide, magnesium trisilicate, and dimethicone. When a person takes NewGel, the raft-forming alginate physically blocks reflux through a unique mechanism. When alginic acid comes in contact with the gastric acid, the raft-forming alginate, which includes natural algae, begins to form a light but strong foam barrier known as raft. This raft floats on top of the stomach contents and prevents acid from moving upward to the esophagus. The alginate raft formula, containing balanced antacid components, offers a speedy onset of action in less than 5 minutes and provides rapid relief from acid reflux with effective neutralization of stomach acid. NewGel has long-lasting effects up to 4 hours, since the raft can be retained in the stomach for several hours. Dimethicone in NewGel is an anti-foaming agent. It reduces the surface tension of gas bubbles, causing them to combine into larger bubbles in the stomach, which can then be passed more easily by means of belching. Dimethicone thus relieves flatulence. NewGel is recommended in hyperacidity, GERD, gastroesophageal reflux disease, gastritis, flatulence, and as an adjuvant to NSAIDs. NewGel is available as NewGel 200 ml suspension and NewGel tablets with delicious mint flavor. NewGel is safe in pregnancy. NewGel is sugar-free, hence safe for diabetics. For patients with symptomatic pain due to gastric and duodenal ulcer, Indus also presents NewGel O, the alginate raft-forming antacid with mucosal anesthetic agent oxytocin. Oxytocin is a potent, safe, local anesthetic agent that provides prolonged anesthesia of mucous membranes, thereby offering prompt and prolonged relief of pain. New Gel O is available in 200 ml suspension with mint flavor. New Gel and New Gel O. Raft formation reduces intensity and frequency of reflux attacks. Works in less than 5 minutes. Offers long-lasting effect up to 4 hours. Sugar-free, hence safe for diabetics. Delicious mint flavor improves patient compliance. We thank the entire medical fraternity for supporting Indus in our journey towards better healthcare.
Welcome everyone back. It is my pleasure to introduce our next speaker. Her name is Dr. Sandra MacLeod. She is a consultant dermatologist and was formerly head of the dermatology department at the Kingston Public Hospital and National Chest Hospital. Recently retired. She's a Commonwealth scholar. She pursued postgraduate studies in dermatology at the St. John's Institute of Dermatology in London. After completing her postgrad studies, she worked in the UK, rotating through the disciplines of dermatology, rheumatology, geriatric medicine, and internal medicine before returning to Jamaica. She has worked at Kingston Public Hospital and National Chest Hospital since she returned. She's a member of the Dermatologic Association of Jamaica and the Caribbean Dermatology Association. She delivers many presentations on various dermatologic topics at local and regional conferences. And she reminded me to be brief so that she could give us more information in her topic, which of course is skincare of the foot at midlife and beyond. Not everything that glitters is golden. Thank you very much, Dr. MacLeod. Please start. Over to you, Dr. MacLeod.
Yes, thank you so much. I must apologize to everyone. My camera is on the blink, so please listen to the sound of my voice. So thank you for that introduction, and yes, let's get right in it. Everybody's hearing me okay?
Perfect.
Yes. Perfect, okay. So yes, thank you for the introduction. So issues related to the feet are important at any stage of life, but increasingly so as we age. Our feet are amazing machines, a fantastic fusion of form, fit, function, and special features. A marvel of architectural and engineering design and precision. 25% of the bones in our body are in our feet. And as you see, the detail in design is really quite astounding. Our feet account for only 2% of body weight, or less as we gain weight, but have to support and transport the entire body. Like the psalmist David, I too can declare that we are indeed fearfully and wonderfully made. Now, having given the feet such a mammoth task, the Lord ensured that they were equipped. The skin on the dorsum or the top of the feet is thin, loose, flexible, and supple. However, the skin of the sole is uniquely adapted to the demands of weight bearing, movement, and locomotion and protection. The sole has the thickest epidermis, that is the top layer of the skin for non-medical people, in the entire body. The dermis has a lot of stuff in there, collagen and so forth. There are more sweat glands and sensory nerve endings per centimeter square in our feet than in any other body part. This helps with thermoregulation and sensation. We have fat pads at the heel and ball of our foot, which serve as shock absorbers and stop us from getting a jolt in our head every time we take a step. The fingerprint pattern of our skin on the epidermis helps to generate friction. So even those little lines serve some purpose. It stops us sliding as we walk. These features ensure that our feet can withstand the stresses of daily activity without undue injury or damage. Now, this diagram shows thick skin, which is skin of the palms and soles. Every other skin in the body is thin skin, and the comparison. So are you seeing my arrow? Anybody? Yes? Are you seeing the arrow?
Yes, we are.
Okay, so yes, so this is the stratum corneum, the upper layer. As you can see, it is very thick compared to thin skin. Not only that, thin skin has hair and thick skin does not. There's also a denser weave. If you look down the bottom, this is thick skin. The layers are much thicker, compacted, as opposed to the loose weave of thin skin. Oops, sorry. Now, below the stratum corneum is the stratum lucidum. Never mind the name, but it's an extra layer found only in the palms and soles. Talk about precision. God is a master worker. That increases thickness and also provides some waterproofing. Our long-suffering feet, we know, are often taken for granted. They are ill-treated. We stuff them in shoes that are just unnaturally shaped, and we ignore them. Talk about overworked and underpaid. Our feet are the ones. But our feet, like the rest of us, change as we age. Our fat pads get thinner. Our feet become more bony. The pressure is not dissipated as well. So we start to feel heel pain and pains in our feet, even the rest of our body, because that pressure goes up through our system. And also we develop calluses, hard skin. Hard skin are a response, calluses are a response to excess pressure. It's like holding a machete in your hand and getting corns in the middle. That's how the body attempts to protect the delicate tissues underneath. But unfortunately, it's sometimes counterproductive. Now, there's also decreased fibroblast. Fibroblast makes our collagen and elastin. This is the scaffolding of our tissues. And with the reduction of fibroblasts, we have less collagen and elastin. Not only that, but the collagen becomes disorganized. Collagen gives our tissues tensile strength as well as elasticity. So the collagen becomes disorganized, the fibers become thicker and stiffer, and it has less recoil. All of this serve to move us toward the development of hyperkeratosis or thick skin, so we get corns and calluses. Our feet are not spared from middle age spread and can get wider and flatter as we age, as the elastin in the ligaments wear out and sag. And so it is that our shoe size can change. We may need wider shoes, even longer shoes, as our feet spread. And those who attempt to wear the same size do their feet a disservice. Our receptors are also reduced, and this ends up with causing a reduction in sensory input. Our sweat glands are reduced, and this affects thermoregulation and moisture retention, which leads to dryness, etc. Our blood supply to our dermis is also reduced, and this affects pretty much everything. It affects tissue viability, wound healing, repair, etc. All of these alterations in the mechanical properties of the skin of the sole as we age leads to increased hardness, dryness, and impaired function. But we can do something about all of that. So don't despair. It is said, once a man, twice a child. And there are actually some similarities between the skin of the newborn and the elderly. So it's between immaturity at one end of the spectrum and senescence at the other end of the spectrum. and the skin share features. Except, of course, newborns are not expected to weight bear or walk, but the elderly are still expected to carry on that function, or feet are expected to carry on that function, even though they are changing. So just a few common skin conditions that I hope to just briefly touch on today. Dry skin, xerosis, callosities, infections, fungal, bacterial, circulatory changes, pigmentation, may be benign, racial, but can also be more sinister. There are other dermatoses, and any skin condition that affects skin elsewhere can also affect the feet. People complain of numbness and burning on the feet, and we will have to look at neuropathy. Is it a vitamin B12 deficiency? Is it due to their diabetes? Is it degenerative diseases with spinal stenosis, etc.? So this calls for actual attention to what is the underlying problem. So on to dry skin. Dry skin xerosis is due to an increase in transepidermal water loss. And this is from all of that stuff I've been studying, collagen and everything, just not as sharp as it used to be. Dry skin feels uncomfortable. It feels tight, and it may become itchy and can crack. Now, dry skin can get so bad that it can progress to inflammation and development of asteatotic eczema, or sometimes they call it eczema craquelé because of how it looks. And this is a vicious cycle because the skin is dry, it becomes itchy, you scratch it, it cracks more, you lose more water, it gets dry. It's just a vicious cycle. This is most common in the elderly and is influenced by hygiene practices and environmental conditions. Sometimes the elderly are not into moisturizing so much, etc. Now, xerosis may also be secondary to other skin conditions, other dermatoses, as I said, that you may find evidence of elsewhere. Or it can indicate an underlying medical condition. So if you have dry feet, you need to be examined. Is it just the feet that are dry? Is all of you dry? Are there any other symptoms of any other condition? And so this may actually need investigation, because correcting the underlying problem is part of the management. These would have to be specifically addressed as well as managing the dry skin. Now, we have all seen this, all right? Not only are they unattractive, all these cracks and hard skin, they are uncomfortable and can be downright painful depending on the depth of these cracks. It's also no fun for others. Just imagine you deciding you want to play footsie with somebody. No, this isn't on. Very uncomfortable. And again, as I will say throughout, cracks are a portal for infection. And this is always important with aging skin, who are people who are more prone to the non-communicable diseases, diabetes, etc. It's important to not have cracks. Now, I call this the Drizella syndrome. And for those of you who don't know, Drizella was Cinderella's older stepsister. Maybe she was middle-aged. So if you see corns on the top of your toes, this is invariably due to ill-fitting shoes. And so you see this foot, the shoe was too narrow, corn here, too narrow and probably even too short. And so the toes buckle and you get corns up on the top. All right, please note that this person also has a fungal infection going on here in the toes. So you look for one thing and you will find other things. Now, as I said before, the development of callosities and corn is the response to excess pressure and friction. So apart from all the physiological changes that I've mentioned, other things, the poor footwear, structural deformities, impaired posture. Somebody has arthritis in a knee, so they are trying to spare that, so they put more pressure on one foot. The shoe is too hard inside, etc. All of these now can lead to callosities. And there's a problem with that. Callosities and corns cause pain. They cause further damage to the underlying structure of the tissues, the foot. So these are seed corns, and they can be deep-seated and painful. A callus is more diffuse, can involve a wide area, but it's more diffuse. And I just want to show you the skin markings in a callus. So you can see they're actually a little exaggerated, but those are the skin markings, the lines of the skin. You can differentiate a viral wart from a callus, as a wart will have lost the skin markings. You may also, if you shave off the top of that thick skin, you may also see in a wart black dots, which are thrombosed capillaries. So this will allow you to decide, is this a callus or a wart? And although there's some similarity in treatment, the management varies a little bit, and you want to know what you're doing. So on to fungal infection of the feet, tinea pedis. This is quite common in the adult population generally, but may be even more detrimental as we age and for those with other medical conditions. So the interdigital tinea pedis, that is between the toes, is the most common. These can be dry and scaly or macerated. They can become cracked and secondarily infected. And many of the patients admitted for cellulitis, this is an infection of the skin of the legs for my non-medical people, are found to have tinea pedis with cracks as the portal for infection. So looking at this feet, that maceration is cracked, scaly as well. See also that the nails are also involved. So this is fungal infection of the nails. Scaly, it's thickened, it's yellow, underneath it is lifted, lots of things going on in this foot as well. I just want to point out that the skin is also dry. And you can see these extra lines here. This is not just age, it's called lichenification. So there's been a little bit of probably itching. And we see this area here, which is a dermatitis. So there is some inflammation going on there. But also this foot is swollen. It is possible that this person has chronic venous insufficiency with a stasis dermatitis. But of course, there are other causes of a swollen foot, edema. So just to remind you, yes, we said this, the nail changes, and they may be dark, they may be light, they may get very thickened. Also, for physicians, please remember to check the groin. Or if you've checked the groin, if somebody comes with fungal infection in the groin, please check the feet, and vice versa. And this is some more tinea pedis. This is the hyperkeratotic form called mocassin tinea pedis. It sort of just goes right around, very scaly and thick, but you can see the ring-like partially. It's better here. You can see the more classic ringworm looking type of rash. And you really want to treat tinea pedis appropriately and early, especially as we age and especially in our diabetics, etc., because it leads to so many other problems. Now, ulcers is an entire topic in itself, but suffice it to say that most ulcers are venous. However, it's important to assess the adequacy of arterial circulation in all patients with ulcers. But this becomes even more important for as we age, for those with the medical conditions that may indicate an arteriopathy, some problems with the blood vessels, such as diabetes, hypertension, the high cholesterol, those who smoke, etc. If they have features of peripheral arterial disease, so the feet are cold and dry, no hairs on the top of the toes, the pulses are weak, you want to just assess that ulcer and the state of the vasculature very carefully. Now, I want to talk a little bit about acral lentiginous melanoma. And I bet most people have seen the Bob Marley movie and now know that Bob Marley died from an acral lentiginous melanoma. Most unfortunate and unnecessary. Now, melanoma, people think that Black people don't get skin cancers. It is true that skin cancers and melanoma are much less common in Blacks. However, acral lentiginous melanoma is by far more common in Black and skin of color people, really much more prevalent. So it's usually the feet, the soles, and the nails, but it can be the hands too. It is a significant problem in Jamaica, and most people seem to be unaware despite our attempts at education. The numbers are increasing too, but the real problem is that they are presenting late with local and distant spread. This has already spread deep. You'd be surprised the depth of this cancer here now, and this is already local spread, perhaps distant spread. We lose people to melanoma in Jamaica. Now, sometimes patients are saying they go to clinic or they dress it themselves, and that's been going on for months before they reach us. No, we want you to send off these people right away. I want you to beware of the red herring. Now, Bob Marley's red herring was that he was playing football and somebody stepped on his toe. We have other red herrings. I got stuck by a thorn, the cat bit me, or something like that. And so they excuse away the condition because they think they have an explanation. Now, some of this, of course, is racial pigmentation. So our skin does get dark. Notice that this person has a little callus going on here. So lots of things going on in this photo. But early detection is key to survival in acral lentiginous melanoma. We lose them because they are coming late. So everybody pay attention to your own feet and the feet of the others. Physicians, look at everybody's feet. And just to remind you of your ABCDEs, everybody just needs to know this. It's pretty simple. You have a mole or a spot, it's dark, you've had it for 10 years, but suddenly it's not as nice and round, or the borders are irregular, the color is changing, it's not nice and even, it's getting wider, especially if it's more than a few millimeters, and it's changing. So you want to just check these out. Diabetes mellitus worsens every single skin problem in the feet, everything. So they get fungal infections more because of the hyperglycemia, and those easily get bacterial infections. They have poor wound healing because of their vascular injuries, issues. So before you know it, they are losing toes, there's nerve and joint damage, and all of that leads to increased pressure. They have decreased sensation. The decreased sensation, and also if they have amputation, the biomechanics of the foot is not the same. So they are putting pressure where it should not go. And so they develop callosities. And that leads to neuropathic ulcers. And that cycle just goes on. It really is just a perfect storm. Are you hearing me?
Hearing you clearly, Doc. Sorry for the interruption. Wonderful presentation. We have 1 minute left.
All right. Okay. I'm speeding up. All right. So diabetes, this is the neuropathic ulcer. This person lost 4 toes. And so this area became under unusual pressure. And notice first the keratin builds up because of the pressure. And then underneath that, it caves away. And so you get the ulceration. Notice that also the keratin layer, the hyperkeratosis has been removed, and the ulcer is beginning to heal, but it's actually bigger than you thought. Now I've compared the car servicing to the care of our feet, preventive maintenance, replacement, scheduling, depending on how we use our cars, dealing with problems. We get warning lights, strange noises, we run to our mechanic. The same diligence should be applied to our feet. And this is my last slide. So the care of the skin of the feet. Site, we have to inspect the patient, caregiver, the physician. When your patients come in and you're checking their blood pressure and sugar, look for their feet, look at their feet, look for the scaling, the dryness, the fungal infection, etc. Sensitivity, especially in our diabetics. He who doesn't feel it doesn't know it. I had a patient who went to sleep in her chair and rats bit her toe and she slept through the whole thing. She ended up losing her toes. You have to keep so it's more important for those who have lots of sensitivity to employ sight to examine. Your feet need to be soft. You need to moisturize so you can decrease the transepidermal water loss. Smooth, gentle abrasion, rub away the thick skin regularly. Don't let it build up. You may need to do more soaks or some keratolytics. You may need to go visit the podiatrist for help. Keep the feet supple. Again, moisturize, but exercise. You can also massage. That's just to keep everything more supple. I have square hair for nails. Cut your nails square so that you don't develop ingrown toenails. So you can see the letter of the day is S. All right. There's a lot more other nail care, but that's a whole talk in itself. Your shoes need to be well fitting. You may need insoles to pad your heels and ball of your foot to prevent to reduce the pressure as the fat pad thins. You also need non-contact insoles, as I explained, for the diabetic neuropathic ulcers to offload that pressure because they won't heal otherwise. You need to slim down, take the weight off their foot, give them less weight to bear. Specific conditions need to be managed, addressed properly. And then you may need specialist care. When to refer to the dermatologist, the podiatrist, etc. Okay, and I have suspicion. We need a higher index of suspicion for certain conditions. You don't like how something look or feel, just pay more attention to it, observe it more closely, or refer if you are suspicious. And so, as we age, we want to take better care of our feet so that we indeed can keep walking. Thank you.
Thank you so much, Dr. MacLeod, for that in-depth. And actually, you did it so well, making it quite simple for everyone in the audience to understand. I'm going to crave everybody's indulgence by actually, for your presentation and the one afterwards, to do the questions and answers at that time. So we're going to combine two to make up for time. So Sam, can we go into the sponsors highlights? Thank you. And please, Dr. MacLeod, please stay so we can
Yes,
actually.
thank you.
Thank you so much. Excellent.
You're welcome.
Sidial, your Abbott Nutrition representative. With observance to your theme, we at Abbott Nutrition are acutely aware of the role nutrition plays in keeping you walking in health. While this slide might speak specifically to pressure injuries, the general message is clear. Proper nutrition can help support strong skin and muscles, don't forget bones, and will help promote healing. Note that quality nutrition is comprised of calories. Adequate calories will help maintain muscle mass and weight. Protein repairs and maintains tissue and muscle, which can help pressure injuries heal. Amino acids like arginine is a conditionally essential amino acid that is critical for wound healing. There's water. Proper hydration carries nutrients throughout the body. Vitamins and minerals. Many vitamins and minerals are associated with healing. Now, may I remind you of the quality options for nutrition support that Abbott Nutrition provides. For people experiencing unintentional weight loss, Ensure Complete is the only complete and balanced nutrition shake with 350 calories and 30 grams of high-quality protein to help gain weight and maintain muscle, along with 25 vitamins and minerals and 4 grams of fiber. We know that when people are pursuing intentional weight loss, considerable weight loss may occur quickly and most rapidly early on. Now, 11 to 50% of weight loss may be from muscle mass. So, consuming high protein during weight loss helps preserve muscle mass and supports weight maintenance. And max protein is the only nutrition shake with 30 grams of protein, 1 gram of sugar, and 4-gram fiber blend with a prebiotic again to support the balance of good bacterial growth in the digestive tract. Remember your Ensure plant-based protein. It's soy-free, dairy-free, 20 grams of protein sourced from fava beans and peas, so it's contraindicated in your persons with G6PD deficiency. It's only 180 calories, no artificial sweeteners, flavors, or colors. Now, Glucerna Hunger Smart. Think 180 calories, 1 carb exchange for your persons living with diabetes, and 15 grams of protein, and 4 to 6 grams of fiber, depending on the flavor. That's your Glucerna Hunger Smart. Now we know that there may be wounds involved in the management of your patient. Hard to heal wounds can take a toll on your patients and keep them from living their best lives. Here's Juven from the makers of Ensure. Pressure injuries, diabetic foot wounds, surgical incisions, or other acute and chronic wounds. Poor nutrition can lead to wound complications, delayed healing, and risk for dehiscence. Juven is a medical food that features key nutrients to help support wound healing from the inside out. Remember, we spoke about amino acids, arginine and glutamine, micronutrients, vitamin C, E, B12, and zinc, collagen protein, a type of protein that stimulates internal production of collagen, and your HMB, that metabolite of leucine shown to slow muscle breakdown and enhance protein synthesis. Juven, twice a day in addition to food. It's a very tasty drink, comes in your fruit punch or your orange flavors. Now, Juven has been clinically shown to support wound healing in chronic and acute wounds. Look at your pressure injuries. Juven increased viable tissue after 2 weeks in patients with stage 2 to stage 4 pressure injuries by 66%. Surgical incisions. Now, if there's an increase in hydroxyproline, then it says that collagen production is happening. And Juven increased hydroxyproline production by 67% in 2 weeks. For your diabetic foot ulcers, there's a 74% increased likelihood of healing in your patients, both with reduced albumin and poor blood flow. So we said at Juven, it can be your Ensure Complete, can be your Ensure Max Protein. Remember, optimal nutrition provides strength for the journey. I thank you.
Thank you.
All right, well, definitely we want to thank Abbott for their presentation. We're now waiting for our next presenter, who I'm hoping is online, and we're looking for the representative from, there they are, Rivas Pharma. Not hearing.
We're not hearing. We're not hearing
I think
you.
we need it to be shared with audio. Please, Debbie. Thanks. So stop your sharing and then share again. Okay, thank you.
Sorry, Sam, I'm sharing it for her.
Okay.
Share with audio. All right, let me try again.
Yes. You should see us
Gotcha.
to go.
Yeah, I
There
see.
you go. Yeah, you saw it. Right. Share with sound.
Rife.
Yeah, we're hearing it now.
Good afternoon, everyone. I would like to take this opportunity to thank Dr. William Brown and his team at Jamaica Midlife Health Society for the invitation to be a part of your CME-accredited webinar symposium. My name is Debbie Neal. I am the area field manager for Rivis Pharma, and for those of you who don't know, Rivis Pharma is a fully Canadian-owned pharmaceutical company that has been operating in Jamaica and a number of other countries for over 20 years. Based on the topic that you're looking at today, which is foot care, I would like to highlight 5 Rivis brands that would be relevant to the healthcare practitioners in attendance. The first is Pios, which is our pioglitazone, available as 15, 30, and 45 milligram tablets. Please note, Pios is the only pioglitazone brand available as 45 milligram tablets. We all know how difficult it is to control some of our diabetic patients, and so sometimes the maximum recommended dosage is required and is available to your patients as Pios brand. Okay, outside of our pioglitazone, we also carry 2 antibiotics which would be relevant if your patients develop skin and soft tissue infections in that area. We carry Moxiclav, which is our amoxicillin clavulanic acid, available as 625 and 1 gram tablets. And of course, we carry Cefure, which is our second generation cephalosporin cefuroxime, available as 250 and 500 milligram tablets. Our third product is our broad spectrum antifungal Itra, which is our brand of itraconazole. And our Itra is available as 100 and 200 milligram capsules. Most of the indications for itraconazole, which includes onychomycosis, requires 200 milligrams. And so it's the 200 milligram capsule that I would like to highlight because it offers better compliance for your patient, of course, and a lot less in terms of the pill load. It is also more affordable for your patients to go with the 200 milligram capsule. So please remember ITRA 200, all the practitioners in attendance. And the final product I would like to remind you of is our NSAID, Diclo-K, which is our diclofenac potassium. And please remember, for patients who have pain and inflammation in that area, Diclo-K is the most affordable option as a diclofenac potassium on the market. If there is any healthcare practitioner who is not currently seeing a medical rep from Rivis Pharma, feel free to reach out to the Jamaica Midlife Health Society for our contact information, and we will be happy to make arrangements for you to be seen by one of our medical reps. We can provide you with more information on these products and other products in the Rivis Pharma line, and of course we can provide you with dose cards, we can provide you with samples. So we look forward to hearing from you, and we hope that you enjoy the rest of this webinar. Thanks again to Dr. William Brown and his team. All the best to you all.
Thank you, Rivis and Abbott, for sponsoring us. And let's go on to the next presenter, and that is Dr. Karen Phillips. Dr. Karen Phillips is a consultant physician and former head of medicine at Kingston Public Hospital. She is an associate lecturer at the University of the West Indies. She holds a DM in internal medicine, an MSc in diabetes and endocrinology, an MSc in obesity and weight management, and an MRCP UK in diabetes and endocrinology. She's a fellow of the Royal College of Physicians, Edinburgh. She is the co-founder and medical director at Revamp Rehab Center, Revamp Training Institute, as well as co-director at Meridian Medical Specialists. She's also the immediate past president of the Association of Consultant Physicians and has served on the executives of Medical Council of Jamaica, MAJ, and is currently a member of the Specialty Board of Internal Medicine. She loves to read, practice yoga, and meditate. She is going to talk to us about the cardiometabolic and vascular problems that impact the swollen feet at midlife and beyond, one step at a time. Please welcome Dr. Karen Phillips.
Thank you, Dr. Kervin-Dawes, for that introduction. I will just go ahead and share my screen.
Slideshow.
Okay, just getting there. Sorry. Why am I not seeing this lecture?
Sorry, I think it might be blocked on your Mac. If you let me help you here, you might see a request. There you go. Play from start. Perfect.
Allow me to hide this. Okay, so good afternoon again, everyone. And I would like to thank the JMHS for inviting me to present at this very, very important meeting. It is indeed my pleasure. And of course, I'm tasked with speaking about the cardiometabolic and vascular problems that impact the swollen foot at midlife and beyond, one step at a time. It's a lot, but I will try to approach this from a very simplistic perspective, considering the audience. So I hope I won't leave anyone behind. So the outline of this presentation, I will start with a case just for some context and so that we can think about what we're really talking about as we go through the presentation. There'll be a few words of introduction. I'll be looking at the risk factors for swelling of the legs at this point in life. We'll look at the approach to the patient, so the physician's perspective. So, you know, the physician is usually the doctor who is really the detective. We try to solve problems, right? So you look at clues, we try to put things together so that we can come up with a treatment plan and get other doctors on board if necessary. And of course, we'll touch on some preventative measures and end with the treatment. So the case is that of a 68-year-old male with a history of diabetes for over 10 years, hypertensive for about 5 years. And in terms of medication, he was maintained on metformin, 1 gram twice daily, Diavista, 30 milligrams once daily. And for the non-medical persons, those are both diabetic medications and a hypertensive medication, nifedipine, 20 milligrams twice daily. Now, Mr. 68-year-old male here, he's a chronic active smoker of 10 cigarettes per day for the past 30 years, and he denied established diabetic and hypertensive complications when asked. So when we talk about diabetic and hypertensive complications, we're talking about strokes, heart attacks, kidney disease, peripheral arterial disease, or peripheral vascular disease, which would include both arterial problems and venous problems. And of course, some autonomic problems, which may be more commonly recognized as erectile dysfunction in males and other issues. So he presented with a 2-month history of progressive leg swelling. He denied shortness of breath at rest, and on lying flat, but he did admit to shortness of breath on exertion. Upon presentation, his BP was elevated at 170 over 100 millimeters of mercury. Of course, we'd like that to be less than 140/90 for him. A pulse of 72 per minute, respiration of 22 per minute. He was not febrile, normal temperature of 98.6, but his glucose was elevated at 40 millimoles per liter. So on examination, what was important was that he was noted to have pitting, and by pitting, I mean there was an indentation to the legs when we tried to palpate or press over the bony prominences of the legs, both of them, up to the knees. There was no elevation of the jugular venous pulsation for the doctors among ourselves, and there were no lung crepitations. So the question that we would like to ask about this case, and which I would want you to bear in mind as we go through the presentation, because we look at them at the end again. What is the likely cause of this gentleman's symptoms? What are his risk factors for leg swelling, and how would you treat him? So, leg swelling, or more commonly edema, is really, really common. We don't have local figures. I was indeed looking for some Jamaican figures, but as usual, we generally have to get most of our data from international sources. And in this case, just looking at the prevalence of edema or fluid retention among older US adults, this was found to be 19 to 20% between the years of 2000 to 2016. And peripheral edema, which means swelling of the legs, was associated with older age, female sex, non-white race, low wealth, obesity, diabetes, hypertension, pain, low activity levels, and mobility limitations at a very significant level. For doctors in the house, a p-value of less than or equal to 0.001. So leg swelling occurs for two main reasons, and the reasons are: one, the most common cause, which I just dealt with, fluid retention, and two, inflammation. When we look at fluid retention in more detail, it is more common in older individuals, and there are a number of reasons for this, and we'll go through them as we go through the rest of the presentation. And they actually represent different underlying medical conditions. So there are a lot of conditions that can lead to fluid retention as we get older, separate and apart from just swelling, which is due to inflammation. And a lot of it has to do with just how we approach the symptom. So looking at risk factors for leg swelling as we age, and more predominantly for pedal edema or peripheral edema, age, as we said, is important. So an older age, greater than 50, of course, is important. Overweight or obesity, prolonged standing, long trips or airplane journeys, medications, systemic illnesses, and varicose veins. And we'll go through a few of these as we go along. I think Dr. MacLeod did mention quite a few of these. And in terms of inflammation, so I'm making a distinction between edema and inflammation, because inflammatory causes associated with leg swelling, they typically present with pain. And these conditions may result from joint disease or as a normal response to injury in the tissues of the limb. And the risk factors for these, as I said before, response to trauma, infection. Dr. MacLeod had mentioned cellulitis, which is an infection of the skin, systemic illnesses, and for the non-medical among us, by systemic illnesses, I'm referring to heart problems, kidney problems, liver problems, and other problems of those nature, of that nature, and thrombophlebitis. So going to the systemic causes as the main causes of peripheral edema, again, we're talking about kidney failure, heart failure, liver disease, deep venous thrombosis, lymphedema, hypothyroidism, and what should be here also the venous insufficiency. In terms of inflammation, cellulitis, arthritis or inflammation of the joints, fractures with associated inflammation, and ligamentous injuries. So, sports injuries, etc., or just, traumatic injuries, which may cause problems with ligaments and tendons. And what is important is that when we look at peripheral edema, which I'm basing most of this talk on, what we can find is that in most cases, these patients will end up with decreased activity levels, physical limitations, and at extremes, they may have pain. And as a result of this, there's increased care burden, increased medical costs, and so it's a vicious circle or cycle resulting in a kind of low socioeconomic status, or maybe the low socioeconomic status is in fact driving all of this. So how do we know that, somebody is experiencing leg swelling? It's fairly evident. Most persons would come to you as a physician and they would say, "Doc, my leg is swollen. I've noticed it's swelling in my legs from when?" Some of the things they may mention is that when they remove their socks, the skin right around the area of the socks is indented. So there's some indentation left on the skin when the socks are removed. They may complain of heavy, numb, or itchy skin. Oftentimes patients are referred to me just with heaviness in the legs, and it's not immediately apparent what the cause is. And upon further exploration, we find that that is a problem. There's some swelling in the legs, and there are a number of reasons for this. The skin may look puffy, may look stretched or shiny, and feel tight or painful when the swelling is extreme. So if left untreated, clearly the swelling can get very severe, and this can cause a lot of pain. It can cause difficulty in walking, itching of the skin I mentioned before, ulceration, skin changes. So we're going back to cellulitis, there's increased risk of infection as well. There's increased risk of scarring between layers of tissues, reduced blood flow, which results in poor nutrition to the skin, less ability of the arteries, veins, joints, and muscles to stretch. So as I said before, I'm a physician, and our responsibility in dealing with a patient with a swollen leg is really to find out what is the cause. So we are the detectives on the case, and we are going to do our due diligence. We're going to go into a detailed history. We're going to examine the patient. We're going to investigate the patient. And when we're done, we're going to come up with a proper treatment plan. So in terms of the history, and when we say history, we need to talk to the patient. And history, a lot of, taking a good history really lies in just listening to the patient. So rather than asking, closed-ended questions, just listening to the patient's talk. Because sometimes if we do that, there is just so much information that we get. Many times I will conclude an evaluation with a patient and still have questions in my mind. And then the patient just starts to talk about something else, and then the answer becomes very clear. So what are we interested in finding out? We want to know about the duration of the symptoms. How long has this been going on? Is it acute, meaning is it less than 72 hours, or is it chronic, over 2 weeks? So that is going to be important. The timing of the edema. What time of day is the swelling worse? Do you wake up with the swelling, or is it worse towards the end of the day? Or is it just the same throughout? What about changes with position? Is it worse when you stand for long periods, or is it worse when you lie down? Or is there any difference at all, or no difference at all? Does it affect one leg or both legs? Again, that's very, very important in ruling out localized causes versus what we call systemic causes. So the heart problems, liver problems, kidney problems. And what medications are you on? There are a number of medications, as we will mention as we go along, which can result in swelling of the legs. And of course, we need to, in this age group in particular, and for all patients, but especially in the older age group, assess for systemic diseases, because as we get older, there's more likelihood of developing non-communicable illnesses, diabetes, hypertension, high cholesterol, etc. So we want to spend some time looking at, a history for those things. And a focused examination outside of the general inspection and evaluation. In particularly, we're going to be looking for signs of heart failure, signs of renal disease, liver disease, thyroid disease. And in assessing the swelling, we definitely are evaluating to see if the swelling is pitting, or does it indent, or is it non-pitting? And I'll show you the difference as we go along. Is it tender? Are there any associated skin changes? So this is an example of what we call pitting edema. If you'll notice, there is an indentation in both legs, which would have been left by, from somebody who would have been palpating the limbs. This is a picture of a patient with venous insufficiency on a background in varicose veins. You may see a few of them, but what I'm showing you here is associated skin changes, the hyperpigmentation or the increased pigmentation in this area, thinning of the skin, and in extreme cases, there can be associated ulceration in that area. And here we're looking at lipodermatosclerosis. In this case, this person has lymphedema, and lymphedema means basically this is a non-pitting type of edema, right? And in this case, there is associated thickening of the skin and fibrosis. So this is an example of that. And again, here is another picture of that. And in extreme cases, hopefully we wouldn't see this extreme case in clinical practice, but this is what chronic lymphedema can look like. So in terms of investigations that we want to carry out, as we said, there are basic blood tests that we want to do, bearing in mind the considerations that we have for the problem. And these would include looking at your thyroid function tests to see if you have a thyroid problem, underactive thyroid, which can cause swelling in the limbs, looking at or overactive thyroid like Graves' disease, where you can have a form of non-pitting edema as well. Liver function tests in case of liver disease. Chemistry, so we're looking at our kidney function here, and D-dimer, we're looking to see if there are any markers for clotting, but this can also help us in other cases as well, say for malignancies or severe infection. A D-dimer can be elevated. And depending on what we think the cause is, a duplex Doppler ultrasound examination is going to be important. If we're thinking about heart failure, chest X-ray, ECG, and echocardiogram are also going to be important. And so this is just a flow chart, an algorithm here that I would want to discuss, looking at the unilateral causes of leg swelling. I'm not sure if it is projecting very well, but if we think that the person has a high clinical probability of a clot in the leg, or deep venous thrombosis, then we're going to do a duplex ultrasound. And if that confirms a clot, then we're going to treat accordingly with blood thinners. If there's no clot, we may want to do some other tests, and we think that the suspicion is high, to see if there is maybe a clot higher up, right? If it is that the probability is low, we would want to do a D-dimer. And the D-dimer, as I mentioned before, usually elevated in situations with clot. If it is elevated, we would do an ultrasound again. And if there is DVT, of course, we're going to treat. If not, we're going to look for other, use another method, which is more specific and sensitive. If it is normal, then we would consider other etiologies, such as cellulitis or infection or some other reason for the elevated D-dimer. If we're talking about cancer, there's a history of cancer, pelvic surgery, or trauma. Definitely we'd want to do magnetic resonance venography. If it shows a tumor or thrombus, we're going to do some further testing. If not, and the examination suggests that there's lymphedema, problem with drainage of lymph, we're going to confirm this with diagnostic testing for that, or we're going to consider other etiologies if not. And again, if there is not an indication for cancer, pelvic surgery, or trauma, we are going to do duplex ultrasonography. And if this suggests that there is venous insufficiency, then we are going to treat. Looking at bilateral causes, this may not be projecting very well. Definitely we'd want to start again with the clinical history and examination, looking for any presence of heart failure, liver failure, kidney failure, nephrotic syndrome. If yes, then we must do our evaluation based on the suspected etiology and treat accordingly. And just to mention that one of these conditions can be sleep apnea. So if that is so, then we may want to do a sleep study, polysomnography, which can help us in this regard and treat accordingly if it's positive. If there's no clinical indication of systemic disease and the swelling occurred over the last few days, less than 72 hours, we may think that it may possibly really be related to some medication, possibly. If that is so, you could discontinue the medication. If it is a little longer than that, we may look to rule out other causes of leg swelling. So chronic cases, we're going to look at chronic venous insufficiency, lymphedema, lipema, which is really more fat deposit in the calf areas and lower limbs, and other etiologies. And once confirmed, then we would treat. So I did mention that there are some medications associated with peripheral edema or leg swelling, common, antidepressants, antihypertensive drugs significantly like our calcium channel blockers, very, very important in that. And a lot of people, we shouldn't be using a lot of methyl dopa or Aldomet at this point. But if we are, yes, I can do it. Hydralazine, another drug, which we commonly use, can do it. We don't really use a lot of minoxidil, but again, it can cause it. There are antivirals that we wouldn't suspect, such as acyclovir. There are chemotherapy agents, again, which can cause this. There are other hormonal agents, or estrogens or testosterones can do this as well. And, you don't commonly think about anti-inflammatory drugs like celecoxib, Celebrex, ibuprofen, but they can also cause swelling in the limbs. So we need to bear all of this in mind when we see that patient who's complaining of leg swelling, typically bilaterally. But remember the caveats, even though sometimes patients present and they will tell you that it's one leg which is swollen, you have to be very careful to look out for bilateral swelling, because sometimes it starts out in one leg and it gets more severe as you go along. So definitely, to prevent all of this, we would want our patients to keep active. Physical activity, there's so many benefits. And one of them, walking on from midlife onwards, is keeping active. It's going to keep the circulation going. It's going to strengthen your legs. It's going to give you all of that oomph that you need to keep walking into the golden years. Limit salt in the diet. This can promote fluid retention. Take care of your feet. As Dr. MacLeod said, as we get older, our feet undergo these changes because of collagen elastin deterioration, and we still try to wear the same size 8 or we've always been wearing. So we need to take care of our feet, look out for ulcerations and corns, calluses, maintain a healthy weight. That is so important. Weight is it has earned its own right as a chronic illness, and certainly plays a big role in leg swelling. And of course, if you see any sign of any of these, wear support stockings. So in terms of treatment, we definitely want to treat the underlying cause if possible. We want to reduce the amount of salt or sodium in our diet. We want to use a diuretic in certain cases to eliminate excess fluid. I want to just stress that the gut reaction or the default response should not be just to put patients on a diuretic, because sometimes it can be a negative situation where it really worsens the symptoms over time if that is not really the reason for this swelling. If it's not a systemic cause such as heart failure or kidney failure, which is causing this. Don't forget that there are patients who have low protein levels, which may occur for a number of reasons, that if that is the approach, you will never get any response. If we're thinking that there's a problem with lymphatic drainage, complete decongestive treatment with a lymphedema therapist is important, and long-term class 2 compression stockings. Exercise, as we mentioned before, keep active, keep that circulation going, and losing weight. This doesn't project very well, but I wanted to just highlight on this in terms of unilateral situations. We spoke about DVTs, so deep venous thrombosis, and how that would present with a predominantly unilateral swelling, and how you'd investigate it and treat it. And then also looking at persons with chronic venous insufficiency, which is, for the lay public, they would call this a circulation problem, usually affecting both legs. We're going to look for varicose veins, and we're definitely, in terms of treatment, some of the, supportive things would be compressive stockings, etc. And of course, there are medications that can be used to help this. And if this doesn't work, there's of course surgery, which can be entertained. In terms of bilateral situations, what I would want to mention here would be, say, for example, liver failure causing hypoalbuminemia and heart failure, or hypoalbuminemia and leg swelling and heart failure, which can cause bilateral leg swelling or kidney failure. And of course, examination would reveal swelling to both legs with indentations on palpation, and treatment would be based on the cause. So for liver failure and heart failure, we would want to give the necessary anti-failure treatment for the heart failure, and for liver failure, we treat with diuretics as well, and other medications as indicated. So in summary, chronic peripheral edema is common and persistently affects approximately, again, US data, 90% of the population in the US, but even anecdotally, locally, we see quite a lot of peripheral edema, chronic peripheral edema in our older patients. Of course, it disproportionately affects women, racial minorities, and less wealthy individuals. People living with peripheral edema have more pain, they have more comorbidities or associated illnesses and mobility limitations, and they participate in less physical activity. And in addition to lifestyle interventions, so we spoke about the low salt, we spoke about keeping physically active. There are some novel non-pharmacologic interventions that would be ideal for the treatment. And this is so because a lot of these patients are on a number of drugs. And as we mentioned before, quite a lot of these drugs can be, a culprit. So we definitely want to try to see how we can use our non-pharmacological measures to assist, but when necessary, we have to move towards the pharmacological measures. So again, common in older adults, the most common cause really is venous insufficiency. So in about 60 to 80% of our older adults, and this is because as we get older, our veins become less competent. The second commonest would be heart failure. And management, I really want to leave this with you, involves a comprehensive approach which starts with a detailed history. The examination should focus on the character of the swelling, whether it's pitting or non-pitting, and the associated skin changes. And of course, treatment is dependent on the underlying cause. So going back to our case, our 68-year-old male with diabetes for over 10 years, hypertension for 5 years. He's on metformin, divistonide, nifedipine, chronic active smoker, no complications. He had a 2-month history of progressive leg swelling. So I'm hoping that those among you who would have been listening would recognize that would represent a more chronic cause. So we're thinking more of chronic situations and not an acute thing. He denies shortness of breath and rest and lying flat, but admits shortness of breath and exertion. So this really is suggesting that he's not likely to have significant heart failure based on the shortness of breath only on exertion. His blood pressure, as we said before, was elevated, and his examination didn't reveal findings of heart failure, but confirmed the swelling to the knees. So, what is the likely cause of his symptoms? And so when we say the likely cause, going back, I would want to go back to the fact that he is a diabetic male for over 10 years. We didn't mention his renal function. He's hypertensive for 5 years, but it's quite possible that he may have some renal insufficiency that may be associated with this, or he may have what we call incipient heart failure, right? Additionally, he's on nifedipine, which is a calcium channel blocker antihypertensive drug, which can promote leg swelling, and Divista or pioglitazone. I know the drug website spoke about pioglitazone, but one of the shortfalls with pioglitazone is that it can cause leg swelling. So you want to be aware of that if you're using this in your patients. And the risk factors, as I said before, would be what I just outlined. And how would he be treated? Of course, if we can, we would want to start with switching out his medications to ones which would not cause leg swelling or be associated with leg swelling. And we really want to do some more detailed evaluation of his heart with an, ECG echocardiogram, and of his kidneys, looking at his protein in the urine and just his renal function. Additionally, be useful to look at his liver function as well, just to be sure. So that is the approach. And I think I'm at the end of the presentation, so I'll await any questions. Thank you.
Thank you. Thank you, Dr. Phillips. Another excellent in-depth. You actually simplified things quite a bit for our audience. We appreciate that. Thanks again. Right now, we're going to have question and answer for both your presentation and the presentation on skincare by Dr. MacLeod. Please use the Q&As and we will have both speakers answer. I think there's a Q&A already, one already in the Q&A. You want me to take it or
Yeah,
you want
Doc.
me to ask?
Sure. From Dion Harrison, please address the issue of people using types of homemade remedies. This was for our first presenter.
Me? Hi. I saw that question. I didn't realize it was for me. Homemade remedies. That depends on what you're treating. There's nothing wrong with homemade remedies. So your feet are dry and you have coconut oil. Yes, you can rub some on it. You can have a little foot soak with a little bit of baking soda in your water, a little salt. That's okay. Now, I would suggest though that the challenge is to know when it's not enough and when you need to seek medical care. And so if it's something simple, if you have an infection, if you have a fungal infection, your toe webs, and your toenails, and so you should get somebody to look at it. If you're having dry skin that you're not able to manage, it's not coming under control with your simple measures, go and look about it. You have an ulcer, you have a wound, especially if you are someone who have other medical problems, then you should want to look about it earlier rather than later. So the short answer is that it depends. Sorry, Miss Harrison. I wasn't very helpful with that. But there are places for home remedies. And as I say, the earlier you start and the more you do preventive maintenance is the more those things will have a place. But if things begin to progress, then you will need perhaps a little more help. Okay,
Thank
I
you
hope
so
that
much.
helped.
I think that was a great answer. So for Dr. Phillips, what about people who like to walk barefoot, like our famous musicians? What are the risks with the feet?
I think that question would be better served by Dr. MacLeod, answered by Dr. MacLeod. But of course, as she spoke about, as we get older, there's some callus formation or some thickening of the sole. And I think persons who walk a lot barefoot would kind of develop that kind of protective mechanism. But generally, it's not a good idea, and especially for persons who are diabetic or have, comorbidities, which, where their immune system is compromised, because definitely you're opening up yourself to trauma and, injuries that are not really necessary.
Oh, Sam, just read the question and let them choose who to answer in this one. Go ahead.
No problem. What causes protein in the urine, as was mentioned?
Okay, so there are a number of things that can cause protein in the urine, and it's one of the unfortunate things because persons who would go for an insurance medical will sometimes come back and they want to rate them because they're protein in the urine. But sometimes protein in the urine can be just from your posture, it can be because of exercise, but then of course there are serious things that you can have. I guess most serious is kidney failure you're thinking about, or nephrotic syndrome, which is a problem where the kidney is filtering too much protein in large amounts, and it can be associated with other illnesses. But infections as well can cause protein in the urine. So there are a number of causes, but it's not something to ignore. But always remember that if you get just like a trace amount of protein in your urine on a simple dipstick test, the real thing to do is to just repeat it at another time in the early morning. Because as I said before, there are a number of things that can contribute to making this, not very specific.
Thank you so much. I think I'll try to join these two questions Is there a one-size-fits-all solution of foot care for spots and itching on the feet? Also, what's your recommendation for sweaty, smelly feet?
That's Dr. MacLeod.
Yes, so those are two questions. Itchy spots on the feet would need to be diagnosed. Do you have a fungal infection? Do you have an eczema? What is going on? Why are your feet itching? And where are the spots? And do you have spots elsewhere? And so forth. So it may be that you have something localized. Maybe you have a fungal infection. Maybe you have an eczema. Maybe if you have psoriasis, there are many other things. So again, this would require you to go and get your doctor to look at that. What's going on? Is this something very localized? Is it just a little itching? Is it just dry? Because as I said, dry skin will itch. So depending on what is the cause for that itchy dry skin, then the treatment will need to be tailored. If the skin is dry, of course, it always needs to be moisturized, no matter what is the cause. Now, as for smelly something feet. What was the other part of that? Smelly. There was something else she said. Smelly and what kind?
Sweaty, smelly feet.
Okay. So actually, as you get older, your feet are going to sweat less. But some people do have sweaty feet. A lot of the sweaty feet is really a neurological response. You hear Dr. Phillips talking about autonomic nerves, and people's feet sometimes get sweaty if they're nervous or so. Yes, there are management. Some people do have a real problem. Their feet get very sweaty. Their shoes are always wet and so forth. And yes, there are management for that will have to be tailored. And so it depends on the severity of the sweating, the timing of the sweating, because sometimes you may need some biofeedback. But what do we do if your feet are sweaty? We can put antiperspirant on it. Now, don't just go use the one under your armpits, please. There are things to reduce sweating. And if that doesn't work, there are other more advanced treatment that one can do. One should keep one's feet dry, of course. Slippers rather than slippers, comfortable, soft, rather than enclosed shoes. And for your feet, remember now that the feet, because they have all these sweat glands, do sweat, and that also promotes bacterial growth. So make sure your shoes are clean. Don't bother fill them up with bleach, but clean what will clean, wash what will wash, wipe out carefully. Make sure your feet are washed between the toes, washed, dried well, and so that will help with general sweaty, smelly feet. So it's also about good care, but if you are not managing that problem, then it's time to see a dermatologist. I think those are the two questions, yes.
Perfect answers, thank you. We have a lot of questions left, but I think we'll just try to do 2 more questions based on time.
But look in there. Where are you seeing
What
those
would be
questions?
they're in the Q&A function in Zoom.
Oh,
What
okay.
would be the cause of constant muscle spasm, or what we Jamaicans call muscle contract in the legs? This happens every night, more than once.
Muscle contracts. Okay, so there are a number of reasons why you can have muscle contracts. I think the most simple reason perhaps would be, something like dehydration, just not being adequately hydrated. But there are other things, and so persons who are having persistent what you call muscle contracts should really go and get a medical evaluation, at least to look at certain, electrolytes in your blood, things like your calcium level. These things, if they are out of whack, can cause muscle contracts. But a lot of times it's really, just dehydration, or maybe, the leg in a particular position, so you're not really maintaining adequate, circulation. So just to get moving, physically active again. But yeah.
All right, thank you so much. I see that Dr. MacLeod has started to type answers in the Q&A. So for the interest of time, back over to you, Dr. Lisa.
Okay, I just was reading something in the chat, which should have been in the Q&A, but I realized that to see a podiatrist is very expensive. Are there any low-cost podiatrists, or are there? I have a trouble referring patients to podiatrists myself. Or how many podiatrists do we have in Jamaica, or is it very difficult to find them?
We have podiatrists in Jamaica. I know there are some associated with the Diabetic Association of Jamaica. There are other private podiatrists. There aren't many, but they are there. I think if you find them, Dr. Phillips, you can probably tell us a little more.
I'm usually affiliated with the ones with the Diabetes Association, you know, it's Dr. Bernard, etc. But yeah.
Okay, so we can tell them therefore that they can look on the Diabetic Association site, and hopefully, because that we're asking about referrals.
I don't think that many of them, I think they can refer, but if I'm not mistaken, Dr. Phillips, you can correct me, they can also just walk in.
Just walk in to a podiatrist.
Yes. Okay. Thank you to both of you. As you have seen in the chats, the audience thought you were excellent, so did I. And I learned a lot, and I'm sure all of us did. Thanks again, and I'm gonna put you over to the next host for the rest of the meeting. Dr. Magdalena Cooper-Denus. See, you're with us so much now, I'm thinking you're one of us, even though you advise us mostly on finance.
One day I'll be a doctor.
But we need you on the finance anyway. Yeah, we need you on the finances. We actually probably need a lot more of you too.
Yes, Dr. Pensions. Okay, good afternoon again, everyone. It is indeed my pleasure to introduce our next speaker, Dr. Andrew G. Ameerally. I hope I pronounced his name
Apologies.
correct.
So we have sponsors presentations.
Sorry.
High-Tech MDRL Limited. So can the representative from High-Tech please go ahead, followed by Apex.
Arlene Palmer, you're on.
Thank you. Thank you. I was trying to start on video, but it's okay. Good afternoon. And I must thank Dr. Brown and the team at Jamaica Midlife Health Society for inviting us to be on today, partnering with you in this excellent webinar. And I just want to say that the speakers so far have been very, 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 very informative, very interesting. And out of these, two of the speakers I can find that I would like to refer some patients to, and myself. Thank you very much. So I am Arlene Palmer, and I'm the Managing Director of High-Tech Medical Lab. We are located at 139 Maxfield Avenue, that's in Kingston 10. In all the mix of the presentations so far, I've seen physical, clinical, and treatment protocols. But where do we fit in the mix? We are a medical laboratory, private medical laboratory, and we do testings on our patients, medical diagnostic testings on our patients. Our main processing facility, and we have been conducting this testing over 35 years now. So we are not new to the business. Our main facility, as I said, is at 139 Maxfield Avenue in Kingston, and we have collection centers in the eastern part of the island, St. Thomas, St. Mary, and Portland, and also Kingston. We offer services such as phlebotomy services. We offer house visits. And we also partner with associations like yours and other facilities or institutions when we are doing health fairs, or if you have if we are highlighting a month we're celebrating or recognizing the month for diabetes, we partner with persons. So thanks again. We do point of care testing at functions, these health fairs, and some of them include most of them include the diabetes management and lipid management, cholesterols, triglycerides, and the breakdown of the cholesterols, high density lipids, and so on. So from there, we are able to refer patients to the doctors who are connected to the health fairs and to the other areas that are involved. Now, one of the tests that we do in conjunction with the diabetes testing is the HbA1c, and that is the one that checks the long-term control of the patient. And we find that it's very informative, and it actually does a very good assessment of the patient's management over the 3-month or the 4-month period. Our testing profile spans routine tests, tests for diabetes as usual, screening, cancer screening, PSAs, CAs, CA125, to name a few, and pap smears, metabolic testing profiles, and executive profiles that we usually advise a patient to do once per year for complete management. For that complete management, we look at the liver, the fats, the renal, long-term and short-term control of the sugar. For males, we do the prostate, and we also do thyroids as an assessment tool. Now, we do fertility management tests also. Semen analysis is a common one for the males, and other blood tests for fertility. We do STI screenings, and we do both ELISA testings, and we do PCR testings. DNA paternity is a hot topic, and relationship testing, and those are also offered by us. So we stand by our motto, we test so you can be at your best. So in the mix of all of the activities, your doctor's visit and all of that, we are an integral part of the process. All major health cards are accepted by us, credit and debit cards, and you can find us on Instagram at hi.tech.medical.laboratory, or lab, I should say. We can also be contacted by telephone 876-929-7673, and by WhatsApp 876-837-3526. So shoot us a message and we respond. Our email address is hitechmdrl@gmail.com. Once again, it has been an excellent seminar so far. I thank you very much.
With over 25 years in providing quality service, Apex Radiology is Jamaica's premier diagnostic facility. Our services include CT scans, nuclear medicine scans, ultrasounds, X-rays, mammograms, MRIs, and more. We have 3 easily accessible locations in the Kingston area and 1 in Ocho Rios. Our MRI services are offered at our Ocho Rios branch, located at White River North Commercial Complex in White River. With cutting-edge technology and compassionate care, experience the difference with our fast, precise, and comfortable MRI scans. Your health journey starts here, where accuracy meets comfort. Apex Radiology is the clear choice for your diagnostic needs.
Good day, this is Health.
Back to you, Magdalena. Both sponsors are completed.
Okay, thank you, Sam. Thank you, Dr. Ameerally, for waiting. Apologies for being previous before I should have been doing the presentation now. And everybody, I'd like to introduce to you Dr. Andrew G. Ameerally, who is our next presenter. He completed his qualifications and studies between 1999 to 2014. As I reviewed his experience, some of the key points I took out of his CV is that ensure appropriate management for patients admitted to orthopedics at the University Hospital of the West Indies. Institute appropriate management for patients referred to the outpatient department. The other one I really liked was teaching of orthopedic residents and rotating residents in the Department of Orthopedics. And he's also a published author. Not only his expertise is admirable, but also he teaches it. Ladies and gentlemen, I am now privileged and have the honor to introduce to you Dr. Ameerally, Dr. Andrew Ameerally.
Hey, good afternoon, everybody. Just trying to get going. So I'd like to thank the Jamaican Midlife Health Society for giving me this opportunity to present with them again. I hope this will be entertaining for you, and what a tough crowd to follow so far. So here we go, bone and joint care of the foot at midlife and beyond. So I just wanted to start with this picture here and ask if you notice anything. And, you know, the question is there, is this love or is this pain? So when we look at the couple ahead, you can notice that the shoulders are square, the hips are square, but this couple behind here at the back, the woman, her shoulder is square, her hip is square, and the guy, his shoulder is twisted and his hip is twisted. This is more in keeping more with an antalgic gait, or maybe he's just a rude boy. I don't know. I think he's both in love and in pain. So just want to, I can't get this off. All right, so the foot is composed of bones, joints, muscles, tendons, ligaments, and other soft tissues that help us to stand, support the body's weight, and perform activities like walking, running, and jumping. So the bone contains 26 bones, the foot contains 26 bones, 33 joints, 19 muscles, and 107 ligaments. Complex. So we're going to divide the foot into 3 sections. And you can see in the picture there, there's the forefoot, which is the lime green section. And this gives you the bones of the toes and the metatarsals. The midfoot, which gives you the cuneiform, the cuboid, and the navicular, that's the blue section. And the red section, which is the hindfoot, is the talus and the calcaneus. And this is where the majority of your weight goes through when you stand on the foot. And the foot balances it out. The forefoot actually takes about 50% of that force coming through when it's flat on the ground. The foot also have arches. It has 3 distinct arches, 2 longitudinal arch, one on the outer portion and one on the inner portion. So you have the lateral longitudinal arch and the medial longitudinal arch. And just below the ball of the foot is the transverse arch. So the structure of the arch is to actually spread the load out so it can be supported with the least amount of effort. It offers some shock absorbency and it protects nerves and blood vessels from actually getting crushed. The proper function of the foot is required for normal gait. So what is the normal gait? So we're just going to go through what the gait is on one side, but what's happening on one side would be the stance phase, and on the other side would be the swing phase. So it's divided into a swing phase and a stance phase, which gives you a stride. So there's initial contact with the heel, that's called the heel strike. Then there's a loading response. That's when the foot goes flat. And then the mid stance, where the body weight is actually balanced over the foot during stance phase. So that's the mid stance. Then there's the terminal stance as the swing goes through on the other side to become double stance, where you get a pre-swing. And that pre-swing is actually the push-off phase. That's where the foot actually pushes off to give you the power. And then you have the initial swing, then you go into a mild swing, and then a terminal swing. So that's what the normal gait cycle would be. The painful gait, which is the antalgic gait, is characterized by a decreased time in the stance phase on the affected limb. The affected limb is placed on the ground just long enough to quickly swing the unaffected limb to stance. This gait allows the patient to diminish pain by minimizing the weight-bearing time on that limb. The painful gait can be caused by any painful conditions of the lower extremity, such as knee osteoarthritis, hip osteoarthritis, even lower back pain, ankle sprains, and stress fractures of the foot. And there are many more that you will see shortly. So I have foot pain. What is wrong with my foot? So there are many conditions that can be going on, and Dr. MacLeod and Dr. Phillips have covered some of them. There are fungal and bacterial conditions, corns and callosities, warts, Morton's neuromas, dysfunction of the tendons, but we'll cover a few of them, like bunions, ingrown toenails, heel spurs and plantar fasciitis, metatarsal fractures, Achilles tendonitis, ankle sprains. Those are the common ones. So ankle sprains, we'll start on top and move down to the big toe. So ankle sprains are very common twisting injuries to the ankle. The incidence is most common reason for missed athletic participation. One of the most common injuries affecting both athletes and non-athletes, and risk factors include patient-related, which would be limited dorsiflexion, that's being unable to pull your foot up or pull your toes up and get the foot pointing upwards. Decreased proprioception, that's with respect to sensation of the foot on the ground, as Dr. Phillips had covered earlier, diabetes, etc., and neurological conditions that can lead to those conditions. Balance deficiency, weakness again, having a stroke, etc., can cause you to twist your ankle quite easily. Environmental related, typically indoor court sports have a higher risk, such as basketball and volleyball, and outdoor activities with uneven surfaces, as in demonstrated in this picture here, can lead to ankle sprain. Diagnosis can be made clinically with swelling and ecchymosis of the ankle and pain with range of motion. Radiographs may be helpful. We want to rule out a fracture or also a high ankle sprain. So ankle sprains can be classified into low ankle sprains and high ankle sprains. Typically, most of us would see in the majority of our practices lateral ankle sprain, and this classically represents about 80 to 85% of ankle sprains. Medial ankle sprain, a bit more difficult to treat, that's about 5 to 10%, and high ankle sprain, that's usually about 5 to 10%. Those usually need surgery. So treatment usually includes a brief period of immobilization followed by early functional physical therapy. And we can use this as a mnemonic, PRISO, which would be protection or protected weight bearing, rest, ice, compression bandage, elevation, and rehabilitation. Operative management is indicated in the setting where there's a high ankle sprain, or if there's a chronic ankle stability with recurrent sprains over and over. The Achilles tendonitis, typically 3 conditions arise. And well, you'll see more as we go along. The insertional Achilles tendonitis, retrocalcaneal bursitis, and Haglund's deformity, and Achilles tendinopathy. So the insertional Achilles tendonitis is pain and thickening of the tendon at the insertion of the Achilles tendon into the calcaneus. And if you look at, if you see my pointer, this is where the Achilles tendon is going into the calcaneus, and that's usually where the problem is for insertional, as the name suggests, as the tendon inserts into the bone. It occurs in middle age and elderly patients with a tight heel cord. That tight heel cord is because of lack of dorsiflexion. Repetitive trauma leads to inflammation, and then it forms a vicious cycle thereafter. Clinically, the posterior heel pain, there's posterior heel pain with swelling, burning, and stiffness. Shoe wear pain is due to direct pressure, so putting on shoes with a back, compressing that tendon onto the bone also causes pain. Progressive bony enlargement of the calcaneus at insertion site. This leads us on to retrocalcaneal bursitis and Haglund's deformity. So the retrocalcaneal bursitis, again, we can see here in the picture, that little red area is what we call a bursa. It's usually a sac full of fluid, which allows the gliding of the tendon over the area to allow smooth movement. So there's inflammation of the bursa between the anterior aspect of the Achilles and posterior aspect of the calcaneus. So between the tendon and the bone, okay? The Haglund deformity in the X-ray, you can see circled, and even in the bump on the heel, that's the bony deformity pushing on that bursa and also on the thickened tendon in that region, which is given that appearance of that swelling there. Could you imagine putting a shoe on in there with it being tight? Tight shoes, tight hard bone, everything is being squeezed between two hard places. So clinically, pain localized to the anterior and the 2 to 3 centimeter proximal to the insertion of the Achilles tendon. There's fullness and tenderness medial and lateral to the tendon. Pain with dorsiflexion, so trying to force the foot upwards. And there's a bony prominence at the Achilles insertion. Achilles tendinopathy, which is different from the insertional Achilles tendonitis. We can see the insertion is down below versus the tendinopathy occurring about 5 to 6 centimeters just above the insertion. So this picture here just again shows the difference between where insertional pain would be versus where the tendinopathy would be. Typically, this is from overuse, an imbalance of the dorsiflexors and the plantar flexors, poor tendon blood supply, and there's also a genetic predisposition. The patient may present with pain, swelling, warmth, worse symptoms with activity, and difficulty running. So treatment for the 3 conditions we just outlined would be trial of non-operative management, typically starting with non-steroidal anti-inflammatory drugs, such as your diclofenac, activity modification, shoe wear modification, physical therapy. Try to avoid steroid injections in these areas because it will just make the tendon, potentially make the tendon weak and cause it to rupture. Surgical management is indicated in patients with progressive symptoms who fail conservative management. Sometimes some of the patients actually come in with a rupture Achilles tendon. So we have to take those patients to surgery or immobilize them and give them a chance of non-operative management. These pictures here are important because one of the things I like to highlight is that just being at home and exercising, the picture at the bottom with the black pants help to demonstrate dorsiflexion. What you're doing is actually stretching the calf muscles and the Achilles tendon. And maybe that person who asked the question about having cramps in both legs every night, you need to start doing these because your calves are being tight. You need the activity. You need the stretching. Do it as often as you can. The picture above is just showing a different way of stretching the same set of muscles with a towel. And you can see Usain Bolt. He's doing it as well. That's why he wins the 100-meter. He just has a lot of power in his dorsiflexors. All right. So we need to, not in his dorsiflexors, but in his plantar flexors, but you also need that stretch so that you can have maximum movement. Calcaneal spurs and plantar fasciitis. So plantar fasciitis is a painful heel condition caused by inflammation of the plantar fascia, aponeurosis, at its origin of the calcaneus. So we can see on the heel is usually on the inner portion and at the back where there's inflammation of the origin of the plantar fascia. This goes to form part of the arch of the foot. So it affects men and women equally, affects the posterior medial heel, that's the inner back portion of the heel, and risk factors include obesity, decreased ankle dorsiflexion in an athletic population, and weight-bearing endurance activities such as dancing and running. Need good sneakers, need to stretch, need dorsiflexion. Symptoms: sharp heel pain, insidious onset of heel pain, often when first getting out of bed. You know what can stop that? That dorsiflexion exercises I demonstrated earlier. Do it even before you come out of bed, right? And you will see it disappears. Dorsiflexion, that's the key word. May prefer to walk on toes initially, worse at the end of the day after prolonged standing, common to have symptoms bilaterally. So this is just demonstrating the heel spur, which is some calcification within the origin of the plantar fascia. We're not necessarily going to get rid of the heel spur, but we can treat the plantar fasciitis. So prolonged course of pain control, Achilles, and plantar fascia stretching, orthotics, so you need those heel cups to put in your shoes. Rarely surgical management is indicated in the case of progressive symptoms that fail non-operative management. We do steroid injections in them for a couple sessions. However, I don't like to do them regularly and frequently because, as Dr. MacLeod described earlier, that fat pad in the heel can start to atrophy if the more steroids we put in there. But there are other options. Metatarsal fractures. So stress fractures develop when repetitive weight bearing exceeds the ability of the supporting muscles and tendons to absorb the stress and the cushion of the bones. So usually occur in runners who too quickly change the intensity or length of their workouts, poorly conditioned people who walk long distances carrying a load. So these two pictures. So can you imagine person on top running a 5K, just started running and they worked their way up to a 5K and then they decided that, okay, I'm going to do a 10K. And they start doing this more frequently. Chances are, if they have poor nutrition, potentially they can end up with a stress fracture. The new recruits in JDF, seen them quite a number of times for stress fractures because their lifestyle have actually changed and the amount of stress they're actually putting on their feet now is significant compared to what was happening before. Women who exercise strenuously and do not eat an adequate diet may be at risk for stress fractures. So diet is important with respect to exercising as well, and especially in the midlife and beyond. Diet is important, especially bone health. And bone health is key because we need to make sure we get enough calcium in our diet. With metatarsal stress fractures, forefoot pain most often occurs after a longer or intense workout and then disappears shortly after stopping exercise. So in your history, as Dr. Phillips alluded to in your investigation, your first line of investigation, this is the information you may glean. With subsequent exercise, onset of the pain is earlier and may become so severe that it prevents a person from exercising, and it persists even when not weight bearing. So now the patient is sitting down, they're not doing their exercises, they're having swelling of their feet, etc. Okay, so you can see everything is tied in here. Metatarsal fractures, again, the treatment is protocol as per fractures. If it's non-displaced, we treat in a cast with non-weight bearing, versus if it's displaced, then we need to go and do surgery. How to prevent a stress fracture in the foot? Well, according to this individual, she has 3 more sets to go, and she clearly is doing fingers today in the gym. Hallux valgus, or bunions. Nice shoes, right? Well, who designs this stuff? How can they imagine that this foot would fit into that unless your foot looks like that? Yeah? They're nice shoes, but foot doesn't match the design of the shoes. So hallux valgus is commonly referred to as bunions. It's a complex valgus deformity of the first ray. The first ray is the metatarsal, this region here, that can cause medial big toe pain, which would be around here, and difficulty with shoe wear. Okay. So here we go. It's more common in women. They're intrinsic factors. There's genetic predisposition. 70% of patients with hallux valgus have a family history and ligamentous laxity, possible ligamentous laxity. Extrinsic factors, shoes with high heel and narrow toe box. All right, so let's look at some biomechanics now. All right, when you stand flat on your feet, you can see that 50% of your weight goes through the heel and 50% goes through the forefoot. Okay, when you stand in a high heel, 10% of the weight goes through the heel and 90% of your force is driving downwards into that shoe, into the forefoot, sorry. When we look down at the bottom in the middle diagram, you could imagine 90% with that narrow toe box constantly deforming the foot is going to lead to a hallux valgus. So typically presents with difficulty with shoe wear due to the medial eminence. So that is this area here. this area here in the shoe, okay? Pain over the prominence at the metatarsal, that's here. Phalangeal joint, that's this joint here. Possible compression of the digital nerve, the nerve runs right along there. So again, if you have the bone compressing against the shoe, would cause problems with the nerve also acting up. Callosities, because again, hard squeezing soft in between the skin and the soft tissue, leading to callosities. So treatment, shoe modification, pads and spacers. So we can see some pads and spacers here, orthoses, and in more moderate to severe cases, surgical intervention may be necessary. So look at the shoes, okay? On the left, the purple shoes, is this person really wearing the shoes or is the shoes wearing them? Whereas the shoes on the right, the white shoes, the person can actually go about and function properly. So sometimes we need to do surgery. So you can see on the left, before, on the right, after surgery. So this person now can have better shoe wear. And this is the type of surgery that we may need to do, where we have to go and realign the bone, or bones, I should say, in this case, so that we can get a better correction of the deformity. So this is major deformity correction that we have to do. It's not just about shaving down the bump. You have to do deformity correction. And you can see the joint here, the bone is slipping off, but now we have it back in place there, right? By the correction of the deformities. Ingrown toenail. An ingrown toenail is a common problem where the nail grows into the corner of the great toe.
Hi, Doc. Sorry to interrupt. We're just about 2 minutes left.
Sure, I'm almost finished. So we can see that here the toenail is growing inwards into the soft tissue. And again, this usually results from cutting the toenail too short into the corners. Again, you can see here, cutting the toenails into the corner actually proliferates the onset of an ingrown toenail. Again, it may present with an infection, needs to be treated with antibiotics. And visit to your GP is important. Tell the doctor Googles who are advising you, you will call them back. It is your toe. Your GP will probably advise you on soaking your foot in warm, salty water to help soften the skin around your toe and reduce the chances of an infection. Keep your foot dry for the rest of the day. Wear wide, comfortable shoes or sandals. Use of analgesics. Do not cut your toenail. Leave it to grow out. Do not pick at your toe or toenail. Do not wear tight or pointy shoes. So sometimes we have to go and do surgery if there's failed conservative management. And this is the end. Have you tried? Well, these are for you to read.
Thank you. Your teaching skills certainly came out in your presentation.
Thank you.
Thank you so much. Back to you, Sam, for the next video.
So I believe there's a Q&A section. Are we skipping that now?
Yes, we're going to have the two of them together at the end.
No problem.
Thanks.
Good day, this is Health 2000 Canada, otherwise known as H2K. Here are a few product reminders. H2K pentoxifillin extended release 400 milligram tablets. Pentoxifillin is a hemorrheologic agent that works by helping blood flow more easily through narrowed arteries. This increases the amount of oxygen that can be delivered by the blood when the muscles need more. Pentoxifillin is indicated in the treatment of intermittent claudication in patients with chronic occlusive arterial disease. So when patients take H2K pentoxifillin, they should experience reduced symptoms such as cramping, weakness, pain and numbness in their arms, legs, thighs and buttocks, making it possible to walk farther and getting more done before having to rest. Results may be experienced in as little as 2 weeks. Typical dosage is 1 tablet 3 times a day with meals. It is recommended for treatment to continue for at least 8 weeks. H2K pentoxifillin is subsidized by the NHF and is on JADEP. So when you need to improve blood flow and tissue circulation, use H2K pentoxifillin, H2K ibuprofen 400 mg and 600 mg tablets for safe, effective routine management of pain and inflammation. Ibuprofen is a non-steroidal anti-inflammatory drug that reduces swelling and relieves pain in the following conditions: soft tissue inflammation and injury, as in sprains, strains, tendonitis, bursitis, bruises, and stress injury. In painful musculoskeletal disorders such as tarsal tunnel syndrome, rheumatoid arthritis, osteoarthritis, tendinopathy, gout, and chronic low back pain. In upper respiratory infections such as sinusitis, tonsillitis, and pharyngitis. It is also used to reduce fever and to relieve minor aches and pain due to the common cold or flu. Ibuprofen is typically used by adults, however the 400 mg strength can also be prescribed for children 12 years with a minimum body weight of 44 kg or 88 pounds, and children 15 years and older can take the 600 mg strength. Ibuprofen should be taken after meals, and if a longer course is needed, it should be taken with a proton pump inhibitor such as H2K omeprazole or H2K esomeprazole to protect the lining of the stomach. H2K ibuprofen is on JADEP and is subsidized by the NHF. No pain is out of reach with H2K ibuprofen. H2K meloxicam 15 mg tablets, a selective COX-2 inhibitor NSAID used to relieve inflammation, chronic pain, tenderness, swelling, and stiffness caused by osteo and rheumatoid arthritis. With its easy once-a-day dosing and well-documented gastrointestinal tolerability, life can be enjoyed again with H2K meloxicam. H2K Borototal, the perfect herbal companion for wound healing and skin infections. Borototal contains neem, aloe vera, licorice, sesame seed oil, zinc, and asoka. Borototal reduces topical pain, calms minor skin inflammation, treats minor skin infections, and promotes healing. Very soothing for dry, irritated, itchy skin. Borototal is effective on cuts and scratches, nappy rash, dry cracked skin, dry cracked nipples, maskne, blisters and burns, minor sunburn, insect bites, and much more. Borototal is safe for everyone and has shown to be effective and non-irritating for everyday soothing relief with its natural and organic plant and mineral ingredients. For the diabetic foot and minor bed sores, Borototal moisturizes the skin to help prevent ulcer formation, helps the skin heal, and prevents dry cracked skin. You can apply Borototal 2 to 3 times per day over the affected area. Try Borototal Neem Cream, you're gonna love it. Please follow us on Facebook and Instagram. This is Amoy Rickman saying thanks for listening. All our products are available in pharmacies island-wide. Please ask for it. Doctors, please write H2K before the drug name on your prescriptions. Have a wonderful afternoon and week ahead. Goodbye.
Yes, thank you, H2K, for that presentation. I'm going to request everybody's patience for the last presenter who is Dr. Owen Bernard, JP. His background is that he was in the Royal Army Medical Corps, served in many parts around the world. But what I like about reading his CV is that he is president, World Walk Foundation Jamaica chapter. I haven't heard about World Walk, so I hope he'll tell us something either in the chat or in his presentation. From his experiences, he is committed to promoting foot care in Jamaica, the Caribbean, and the world. Ladies and gentlemen, it's now my distinct pleasure and honor to present to you Dr. Owen Bernard, JP, Committed Foot Care Specialist. Over to you, Dr. Bernard.
Are you hearing me now?
We're hearing you loud and clear. Yes, go right ahead.
Yeah, yes, let me just make a quick correction. I am a British trained podiatrist, so we don't use the term doctor, okay?
Oh, okay. Thanks for that correction.
Yes, we don't
Thank you.
use the term. And World Walk Foundation Jamaica chapter, it's an international organization which was formed by Dr. Neil Donahue. It originated out of USA. They believe in saving limbs. You know, they've been a mission all over the world, in Haiti and also. And I've worked with him extensively for the past 30 years. And when I developed the foot care assistant program, although it would be befitting to sort of a form an organizing World Walk Foundation Jamaica chapter to address the foot care needs in Jamaica. So the foot care assistant program comes directly under the World Walk Foundation Jamaica chapter. Foot health in general. Okay, could I have foot care? Thank you for inviting me. It is, I am glad to be part of this very important presentation because it is dearest to my heart. Foot care, I think, is still undervalued, not just here in Jamaica, but in the Caribbean. But things are getting better. Could I have my first slide, please? Foot health and diabetes management, a paradigm shift. And the reason why I use that term paradigm shift, based on what is happening, how it's being done, it needs to change. Could I have next slide, please? Foot health and diabetes management, and in fact, I don't want to keep saying diabetes management because foot health does not relate to diabetes in general. The management of diabetes, a holistic approach, a multidisciplinary approach should be embraced. The complications of diabetes are preventable if they are identified and managed early. Next slide, please. A systematic review identified 3 priority levels of intervention for preventing and treating diabetes and its complications in LMIC, low middle income country. Early interventions are cost saving and highly feasible. Think about the high cost of a patient, the economical factor, with a diabetic also who is hospitalized. Foot care in people with a high risk of ulcer, blood pressure with that value, glycemic control, HbA1c 9%, 75 mmol, etc. Next slide, please. Foot health in diabetes management, early intervention. When we look at this, look at that, that's the slide you're looking on the left. You may look at that foot and say there's nothing wrong with it. Okay, there is nothing obvious, but look at the deformity, and we need to pay attention to it early detection. As soon as that person is diagnosed with diabetes, start the education program process. If you don't, over the years, then this is not something, the slide to the right, it's not something that happens overnight. This starts from a callus. Now, what is not happening? That callus is not being treated, not being managed, not being dealt with as early as possible. If you don't, this is what happens. It leads to that. Now you have a problem. Next slide, please. Foot care. Foot care, however, is not being adequately addressed. Foot care is forgotten discipline in healthcare delivery. Foot care, ask yourself, all the caregivers out there, I am going to challenge you. Ask yourself this question. When was the last time you asked your diabetic patient to take his or her shoes off and actually physically inspect that foot? Foot care is not fully understood by the persons living with diabetes. They're totally ignorant about it. There is also an unreasonable fear of losing a limb once a problem develops. That is simply not true. Reassurance. Next slide, please. Case example. Let's look at the first slide. This is sheer neglect. That is what we call, medical term, onychogryphosis, thick, crusty nail. This is sheer neglect. It did not because that person is old, not because that person is diabetic. They're not resigned to these conditions. No. This is sheer neglect. And what I'm finding in my practice is these conditions are leading to disaster because they are damaging, traumatizing the toe underneath or the toe next to. As per the second one, looking at it, as you can see, the nail on the hallux is now transferred over to the second toe, and by so on. Under that nail is an ulcer. And the third and fourth slide certainly show the extent and damage that can be done. The reduction of the nail has been neglected to the point where it begins to damage the soft tissue, causing an infection and subsequent ulcer. So these things don't have to happen. They have to be dealt with. And we need to have people who are trained and given the right tools to do their job. This could lead to surgery and amputation. That's a fact. Many people end up losing their limb as a result of these conditions. It is so common, these conditions. Early correction and reduction of the nail should have been a priority. Surgery leads to hospitalization, which is an expensive option, both economically and emotionally. It places a burden on all involved, the patient, the family, the caregivers, the hospital, lost productive man hours. Next slide, please. Amputation should be the last resort. Amputation might be necessary, but it fails to solve the problem entirely. A more in-depth approach is needed to achieve this paradigm shift in foot care management in diabetes, or foot care in general. Next slide, please. There should be an integrated foot assessment conducted for patients with diabetes once diagnosed. This places foot care further up the hierarchy in the management process. This form, which we have developed, should include the basic foot problems and deformities. Next slide, please. The approach. Deformities are overlooked. Bony prominence highlights many foot deformities as a result of ill-fitting footwear or those shoes that are designed for people with 3 and 2 toes. The previous lecturer certainly showed some of those footwear that I'm talking about, which can lead to foot problem. Example, hallux valgus, which was spoken about, which is an adduction of the great toe. When that toe is adducted, bony prominence appears. Hammer toes, self-explanatory, and congenital deformities such as pes plana valgus, which is flat foot. Next slide, please. I am recommended that integrated approach, we should have a foot assessment form where you would simply take things off. It embraces everything. It has all the foot condition. For instance, corns. There are 5 different types of corns out there. Not many people are aware of that. In early stage, once a person is diagnosed, that foot assessment is not, and you take things off. Take off as we go along. Simple. As you know, you know, every time I see a patient who is diabetic, I always ask them how, if they understand how diabetes affects their weight, and most of them say they don't. Which is circulation, which in turn affects the nerves. So you have the sensory section, and all you need to do is tick off as you do the assessment of the foot. Next slide, please. Yes, these are all the conditions that we have seen. Okay, yes, after the foot assessment has been done, it may look, seems to be a lot, but this can be done in 5-10 minutes. Okay, next slide, please. Once that is done, we can do what you call a staging. Stage 1, you examine the foot of the patient. Okay, we have examined your feet. There seems to be normal. That is a stage 2. A stage 1. Stage 2, they now have deformities, i.e. the hallux valgus, the hammer toes, etc. Stage 3, you have an infection. Wow, that means something has gone wrong. Stage 4, corns, calluses. Stage 5, ulcers. Stage 6, wet, dry gangrene. And even at this stage, as a podiatrist, I believe aggressive intervention from the team. The last resort should be amputation. Wet and dry gangrene, it depends on how severe it is. But aggressive, I strongly believe that you know, we can prevent that. Stage 7 is amputation. Next slide, please. So the using a simple but structured screening tool will help to identify problems early, effect treatment and care, improve patient education. The tool can be used by lay healthcare personnel once trained. The tool would be used in the referral pathway in foot care management. And we are looking at, because there are no podiatrists in any of the government hospitals, or at least all the podiatrists in Jamaica are in the private sector. So to address that, we're looking at training foot care assistants to deal with these basic foot problems at primary care level. We're given the tools to do the job. Next slide. Recommendation: early screening and intervention. Train of healthcare personnel in all stages of foot care management, including screening, nail care, wound care. Next slide, please. Conclusion: there needs to be a paradigm shift in the management of foot health, especially those in high-risk groups such as the diabetic and the elderly. Early screening of the feet can result in fewer complications and amputation. Why? It identifies early problems. Foot care in these patients should involve patient education, the assessment on diagnosis, involvement of the healthcare team, community health aides, diabetes educators, nutritionists, pharmacists, nurse, physician. We need to train more foot care assistants and give them the basic tools to do the job if they are serious about foot care management. Next slide. Foot health is not a minor matter. Amputation should and can be prevented. Thank you.
Thank you, Mr. Bernard. You notice I got it right this time, right, Mr. Bernard? Thank you so much. I learned so much from that. So we're now, can somebody please mute your mic, please? There's a lot of background noise coming up. I don't know who it is, but please mute your mic. Allgate, please mute your mic. So what we're going to do now is
it's Mr. Bernard's speaker is going back to his microphone. So we're hearing you twice on his end.
Oh, okay. So what we're going to do now is open the mic now, and you can do the questions from the Q&A, please. Thank you. Sam.
No problem. Thank you. From Ricardo Bihari. What is the opinion on weight-bearing exercise like barbell squatting versus running on the feet and knees for clients who are middle-aged? Again, anyone who'd like to take that one?
Dr. Ameerally.
You can repeat the question, please?
What is the opinion on weight-bearing exercises like barbell squatting versus running on the feet and knees for clients in middle age?
I don't think they're mutually exclusive. I think they're both important to be done. There are several factors that we have to look at when we're looking at exercising. So exercise comes from my perspective, I'm looking at bone health. So there's that aspect of maintaining the integrity of the bone, and that's where the barbell squats, etc., come in. So that would be resistant exercises. And then there's the running, which now goes into a different realm of physiology. And that would be talking more about mitochondrial physiology, muscle physiology, and those are important. It also gives the benefits of cardiovascular benefits as well, and respiratory benefits. So they're not mutually exclusive. I think they're complementary of each other.
Thank you so much. This one's from Dion Harrison. At what age should a child start wearing regular shoes? A lot of times you see non-walking babies in hard shoes, sometimes out of trends, possibly. What are the implications there? I think Mr. Bernard is trying to answer. Go ahead.
Yes, can I answer that?
Sure, please take it away.
I am so glad that this has been brought up, because this is something that I promote, foot health in children. I was going to ask the previous presenter, for some advice or question regarding young athletes. Doc, would you recommend young athletes doing pre and post warm-up, warm-down exercise? Because we have to think about, they're still within their developing years. So the shaping of their feet are going to be influenced by certain footwear during that period of time. Am I correct?
You're absolutely correct. So I definitely, again, I endorse warm up and cool down. It definitely helps with the muscles, etc., with respect to stretching. And even those young athletes that may go through growth spurts, then you also have other injuries or other pathologies that might kicking at the same time, like traction apophysitis, etc. So now they're having knee pains, foot pain, like from the calcaneus itself. So you're having additional problems if you're not stretching, etc., in the early phases, So I definitely endorse stretching and cool down.
Awesome sauce. From K. Anderson McIntosh. Where in Jamaica can one get corrective surgeries for bunions?
So there are many places, there are many orthopedic surgeons. You just need to find one that you trust. I do them myself, but there are many orthopedic surgeons in Jamaica.
Thank you so much. So again, direct answer is call me and set up an appointment. All right. How does wearing a low heel shoe affect the weight proportions on heel and forefront of the foot? Hopefully, I've said that question correctly.
Yeah, so low heel shoes, obviously there's gonna be it's gonna be less of that. So instead of 10% and 90%, it's gonna be probably like the lower you get, it's gonna get closer to 50% and 50%, right? That's where we ideally want to be. However, low heel shoes, I'm guessing it's gonna be more 40 to 30% versus 60 to 70% with the forefoot. But again, if you have the shape of the shoes, which are pointed toes, narrow box shoes, then it's gonna also cause that deformity to start occurring. So before, back in the day, caveman days, when they had no shoes, bunions were not a problem.
Thank you so much. So I have a question here. What advice should I give an elderly family member who has developed a deformed toe that is preventing him from wearing shoes now, does he need to see a podiatrist?
He either needs to see a podiatrist or an orthopedic surgeon.
Okay, so podiatrist or orthopedic surgeon, thank you. Any special dressing with chemical debridements actions before surgery? Again, I can't read that one. I'll skip it. Is it safe to do a debridements? Thank you. Let me try that then. Any special dressing with chemical debridement actions before surgical debridements, like alginate or collagen dressing?
This is for what specifically?
All right, so Dr. Ain, we're gonna ask you to say what specifically we're speaking to there. The next question is from Venice. Is it safe to do a regular pedicure once per month and scrub the feet, heels, and toes? And will it wear out the feet? I'm not sure if that's specific to persons with or without diabetes, but I guess it may be a general question. Is it safe to do regular pedicures?
Mr. Bernard, you want to take that one? Not hearing you.
I am getting, can you hear me now?
Yes.
Yes.
I am getting quite a few cases who visit the pedicures with good intention and disastrous. We are not condemning them, okay? But what are you scrubbing? Is it to feel good, or are you scrubbing away excess dead tissue that has built up? So the foot need to be assessed. For the sake of just scrubbing, and some people have very sensitive and delicate skin, so you could create some issue and the problem there. And I find that this is happening. If it does need to be scrubbed, don't scrub it. That is what I would recommend. If you have excess tissue there, okay, and they do this, that's different.
All right, thank you very much. The final question, what would you say about earthing or grounding? I know there was a question earlier about being barefoot and walking. There's a new health practice that has emerged some years ago, but took some prominence late last year about earthing or grounding.
I'm not
What's
aware.
your take on that? Yeah, so being barefoot pretty much and going outside as much as you can and getting grounded with earth that balances your natural pH, etc., in your body.
Wow, I've
never heard of that one.
Never heard of that one. And also, I would be very cautious about, giving information about going outside barefoot, especially in the high risk, especially diabetics. We have to be very careful.
Yes. All right. Thank you very much, everyone.
Especially if there's no sensation on the foot and you go outside barefoot, it can be a disaster.
Yes. The question has reoccurred regarding the baby footwear for babies. At what stage should be recommended that that we wearing footwear, shoes, etc. Let me just say this: when you X-ray a child's foot, a normal foot is 26 bones. When you X-ray a child's foot, say, correct me if I'm wrong, Doc, 5, 6 years, it's fascinating. You see floating bones, correct?
Correct.
Yes, you have to be very careful about. They can wear footwear now. There's nothing wrong, but soft and friendly and comfortable to the feet. Remember, they're delicate. So hard shoes, because some of those footwear are made from very crude material.
Correct. So sometimes there are some pathological conditions where we do have to start early footwear even before the child stands.
Yeah.
So in those conditions, definitely is expected. So like the club foot that we're trying to correct, etc. It's important that we are able to correct those deformities before they become a problem in life.
All right, perfect. Gentlemen, thank you very much. Really appreciate it. I just want to say thanks again to Miss Magdalena Cooper-Deneuve, pension specialist, Of course, Dr. Lisa Kervin-Dawes, who is MD, MPH consultant, internal medicine board certified, and Dr. Anna J. Brown Morgan, MBBS, MSc, DMFAM, Med, FCC, FP, who have led us throughout today, giving us wonderful introductions and moderation. I now hand over to Dr. William Brown, President, JMHS, for the closing remarks before Dr. Anna Brown Morgan does the vote of thanks. Over to you,
Thank you
sir.
very much, Sam. Yeah, very good meeting indeed. Went beyond my expectations, actually. Starting with Prof. Elaine, thank you very much for reminding the JMHS that the feet, actually, that is the balance of the body. And he actually asked JMHS to remember that they are the pivotal set of persons because they can look back and see where they have done wrong or gone wrong in terms of their healthcare and lifestyles, and they can look ahead so that those mistakes can be corrected. So we are at the pivotal point. Very, very interesting. He asks us to look at food problems as a surrogate for chronic non-communicable diseases that impede the development of any nation. And he charged us, the GMHS, to lend our voices, both in the private and public sectors, to let our voices be heard, because together with climate change and these non-communicable diseases, which he mentioned a few, hypertension, diabetes, these are the main existential threats that affect our lives and make us die early or live in a very negative way. He also has to help to identify these risk factors, as I mentioned, diet, obesity, and to exercise more. And also the concept which struck me of all is the rectangularization of life. I'd always look at life as a triangle, but he brought a new concept. Very, very interesting. Well received, Prof. Thank you very much. And then we continue with Dr. MacLeod, who gave us some special features, reminded us of the special features of the foot, emphasizing on the nerve, the sweat glands, and the fat pads, and the changes to these structures as we aged. The fat pad will be reducing, elasticity will be reducing, the sweat glands going down, and vascularity. And then the foot gets wider and flatter, and therefore affects shoe sizes, all right? So in trying to put on all the shoes as we get older, we may develop certain diseases of the foot. She spoke on a few of the selected foot diseases. She mentioned xerosis, which is dry skin, calluses, corns, pigmentation, circulatory problems, and eczema. And I learned something new, the Drizzler syndrome. Thank you, Sandra. We all know about tinea pedis, the ulcers, and the cancers. And she reminded us of the example of Bob Marley, which causes demise. Please be careful and act. And she says that diabetes worsens everything in the foot. Diabetes worsens everything in the foot. She also referred to the servicing your foot as a foot mobile, like a vehicle, right? And lastly, she referred to 11 S's, which I'm trying to memorize up to now. When you have foot problem or foot care, the sight, the sensitivity, the softness of the foot, the skin, the smoothness, the suppleness, the square nails, the shoe type, slim down the weight, specific, and the other one, suspicion, and then the special care reference. That is a specialist reference. Thank you very much, Dr. Sandra MacLeod. Learned a lot. And then Dr. Karen Phillips wowed us with her topic. She mentioned factors for leg swelling, mentioned things like age, weight, prolonged standing, systemic causes like congestive heart failure, kidney disease, liver disease, thyroid diseases. Some medications definitely do cause swelling of the foot, and she went through some of them, and finally she mentioned varicose veins and deep venous thrombosis. He said the causes were two, by and large. One, by fluid retention, and two, by inflammation causing cellulitis, arthritis, fractures, ligamentous injuries, etc. To the doctors, he said you have to be very careful to have a proper medical examination for the patient before the diagnosis is made, a proper diagnosis is made, and to watch the signs and symptoms being presented, to investigate properly, and to treat properly. And finally, she mentioned, highlighted some preventative measures by keeping us active, that is exercise, reduce salt intake, to have foot care ongoing at least twice a year to visit the podiatrist, healthy weight, and also to wear support stockings. And then Andrea Ameerally came up with the orthopod point of view, reminded me, for example, of the structure and functions of the foot. And he went through normal gait, the normal gait cycle. Very interesting to watch and seeing that for the first time. And then he asked a question which hit me. What is wrong with my foot? And I was looking at my foot to see what's wrong with my foot. I was checking to find out if there were really spurs or fractures that he had mentioned, the tendonitis, the ankle sprain, the bursitis, the plantar fasciitis that we often confuse with the spur, the spur, calcaneal spurs, and stress fracture, and then the bunions and the ingrown toenail. Very informative, very informative. And before he finished, he's highlighted on the price. I heard it before, but you can list it down again. Pricer, not price, but price, as he had said. I always look at it as price. The P for protection, R for rest when you have foot problems, I for eyes, C for compression, E to elevate the leg, and finally the R is for rehab. Very, very informative. And then Mr. Bernard Owen concluded by approaching foot care from the podiatrist's point of view. And he believed that this should be approached this way, an integrated foot care approach with doctors, podiatrists, dermatologists, diabetologists, nurses, orthopedic specialists, etc., etc. It shouldn't be one man's point, but the person should be seen by a group of doctors. That is the integrated approach. And he referred to a protocol whereby this group of doctors could be used. So you know exactly what is happening, what is being treated by the other, and with the same form, this protocol, all right? He emphasized early screening and intervention, and that the diagnosis should be made early, and training of persons who need to help in this area. He finalized his presentation by mentioning the staging of the diabetic foot as a normal 1, then stage 2, deformity, stage 3, infection, stage 4, corns and calluses, getting worse and worse, stage 5, ulcers, and then stage 6, wet and dry gangrene. And finally, what we don't want in our patients and for us as individuals is amputation. Thank you very much. The presentations were well taken, and we'll look forward to interacting with you once again. Thank you to all the presenters. Anna, up to you now. Thank you. A vote of thanks.
Yes, it has been a very quick moving afternoon of education and enlightenment. And hopefully we have all seen how we can make our lives and the lives of our older loved ones more comfortable with what we have learned here today. It is my pleasure to say thank you to everyone who played a part in enriching this experience this evening. My many thanks go to Professor Sir George Lane, who by his presence here today has given emphasis to the importance of continued careful health care for our seniors. Jamaica Midlife Society thanks Professor Sir George for taking the time to be a part of this conference today. As our president said, he has reminded us that midlife is a pivotal time to reinforce rectangular living. Thanks also to our speakers, Dr. Sandra MacLeod. Her little point was, as we age, we need to take better care of our feet so that we can keep walking. Dr. Karen Phillips, who asked us doctors to take a good history. Dr. Andrew Ameerally focused on the many causes of painful feet, and Mr. Owen Bernard, whose question was, when is the last time we doctors or the persons who are with us on this webinar actually examined their own feet, especially the diabetics among us. And that, of course, we need an integrated approach to management of the diabetic foot. Our thanks to Dr. William Brown, our president of the Jamaica Midlife Health Society, who welcomed us to the conference with his usual spice and wit and humor, and gave the closing remarks just now, which encapsulated everything from each speaker quite adequately. Our moderators, Dr. Lisa Kervin-Dawes and Miss Magdalena Cooper-Denoez, were competent, sharp, and on the ball, and we thank them for their substantial work in steering us through this afternoon's events. A very special thank you goes to our sponsors, MSN Pharma, Indus Life Sciences, Abbott Labs, Rivis Pharma, High-Tech MDRL Limited, Apex Radiology, and Health 2000, Health 2K Canada Incorporated. We are truly blessed in having your support, some of you over many years, for the Jamaica Midlife Health Society, as we try to support and educate our midlife group of people who need to value and appreciate themselves and their important role that they continue to play in our communities. So we want to thank you very much, our sponsors. Thanks go also to our secretariat, led by Mrs. Lynn Hyatt, who helped us a little bit. I think I mean more here, Marcy. I'd like to thank Marcy Tulloch, and who got all of everything organized and got everything just key. Today, organized the contact with all our participants. And thank you, Marcy. Sometimes I make a little boo-boo there, but it's Marcy. Thank you very much, Marcy. And thanks also to Sam, our IT technician, who we go to at all times to solve all technical glitches. He has never let us down. There's only one set of people left to thank, and that is you, our audience, the physicians and doctors and laymen who are here today and have spent the afternoon with us, learning, listening, participating, and just making this an evening full of warmth and interaction. We hope you were enlightened. Have a great evening, everyone. Good night.
Night. Thank you, everyone.
Thank you very much,
Day
Sam.
well spent.
Very much, Anna.
No
Thank
problem.
you.
Please have a great day. Stay safe. And
Thank
see
you.
at the next webinar.
Thank
You
you.
too,
Bye,
Sam.
everybody.
Bye, everyone.
Thank you,
Good night,
Mosi.
everyone.
Bye again, everyone.
Mosi,
Thanks,
thank you.
everyone. Bless you.